All right, so in the next half hour, I'm going to try and cover topics that typically take about an hour to talk about each. So this is a basic course, so much of what I'm going to say is going to sort of touch on a lot of things that you're going to hear about by other speakers and in other programs through the day. These are my disclosures. These are our learning objectives. And let's start by talking about the epidemiology of MS. It's an inflammatory and degenerative disease of the central nervous system. It's the most common neurologic disease causing disability in young adults. Current prevalence estimates are between 900,000 and 1 million in the United States. The most common age of onset for relapsing MS is between 20 and 40. Fred showed a slide this morning between 15 and 45. We can quibble, but what clearly is happening is we're starting to see cases now in older adults as well, presenting in people in their 50s. We have a term for this. We call it late onset MS. Progressive MS typically presents later. Most people are in their 30s, or in some cases older. Women with MS outnumber men by about 3 to 1. MS is expensive. A large study done by the National MS Society recently published showed in 2019 dollars. The cost of MS to the U.S. economy was over $85 billion a year. In terms of mortality, most studies have shown that people with MS live about 7 years younger than the general population, but interestingly enough, a study that was just published out of a long-term natural history cohort that's followed in New Zealand and Tasmania showed that in the period between 2009 and 2019, the mortality rates did not differ from those of the general population, suggesting that maybe something is changing. Maybe this represents better treatment of MS and other factors such as comorbidities that influence mortality. Certainly it's an interesting study that maybe is a cause for optimism. Now, MS is more common in temperate climates, and higher rates have been described in Caucasians of European descent compared to, for example, African Americans. However, there's been some recent work which suggests that the MS in African American populations in particular is underestimated and may actually be closer to that we see in Caucasians. On the other hand, there are some populations with within these high prevalence geographic bands that don't appear to get MS. So Inuits, for example, in the northern hemisphere, Maoris in the southern hemisphere. Higher latitude has been associated with an early age of onset, and the prevalence of MS is increasing worldwide, and although it's estimated at 2.8 million with a pooled incidence across the world of 2.1 per 100,000, those figures in terms of the world figures may be underestimates. We know that there are a number of environmental factors that are associated with the risk of developing MS, low vitamin D levels and sunlight exposure independently, mononucleosis and Epstein-Barr virus nuclear antigen, and a pivotal landmark study published a couple of years ago looking at military populations and VA medical records clearly showed that seroconversion to Epstein-Barr virus occurred prior to the onset of MS in a small number of individuals that were identified as not being seropositive to Epstein-Barr virus at entry into military service. This is important because it suggests that Epstein-Barr virus may be necessary for MS. All but one individual in that study who had multiple sclerosis had evidence of serologic exposure to Epstein-Barr virus. On the other hand, it's clearly not sufficient by itself because Epstein-Barr virus is endemic in the population, and most adults, at least 95% of adults, have evidence of serologic evidence of exposure to the virus, but don't get MS. Tobacco smoking is a risk factor not only for the occurrence of MS, but it's also a risk factor for worsening MS. Passive smoke exposure. Several studies now have shown, both in pediatric and in adult population, that passive exposure to smoke is also associated with the risk of MS. Obesity in childhood and adolescence, season of birth. If you're born in the spring, you have an increased risk of MS compared to whether you're born in the fall. And evolving associations involve the microbiota, where we have a potential site of immune sensitization leading to CNS autoreactivity, and also the lungs, where airborne pollutants and inhaled toxins can potentially initiate immune sensitization. One study showed shift work in adolescence was associated with MS compared to individuals who worked in a steady hourly pattern. Whether this has something to do with circadian rhythms and their effect on immunology, we don't know at this point. Genetics. The general population of risk of MS in the U.S. is estimated between 1 in 750 to 1.5 per thousand. On the other hand, if an individual has a parent or a sibling with MS, that risk is 3 to 5%. An identical twin increases the risks at 25 to 30%. Large genome-wide association studies have identified over 200 different genetic foci variations in MS called SNPs, and these are usually associated with non-coding regions of immune functions and are thought to act likely by modulating the expression of these genes. As we heard earlier this morning, the strongest association is HLA-DRB1 star 1501, which is part of the mixed histocompatibility complex, which increases the risk threefold. There's a protective gene called HLA-A star 02, which decreases the risk of MS, and the combination of these two factors, in other words, having DRB star 1501 and, or rather not having star 1501 and not having A star 02 increases the risk fivefold, so they act in concert. And overall, these genetic associations to date explain about a third of the risk of MS. So our current favored hypothesis, and I stress the word hypothesis, is that an individual with genetic susceptibility encounters environmental factors which activate immune responses that are directed at central nervous system, myelin, and oligodendrocytes. The risk is amplified by the combination of particular genetic and environmental factors, and a sustained process is established that results in further damage within the central nervous system, which involves both inflammatory and non-inflammatory mechanisms. So briefly, let me talk about some basic immunology. It's a complex issue in MS. It involves components in both central nervous system and peripheral compartments. It involves both the adaptive immune system, which consists of T and B lymphocytes, as well as the innate immune system, which consists of monocytes, macrophages, microglial, CNS dendritic cells, astrocytes, and natural killer lymphocytes. Chronic MS inflammation is thought to involve disruption of immune homeostatic balance between inflammatory activation and immune regulation. And it's currently unknown whether the initial inciting events that result in inflammation within the central nervous system occur because of damage within the central nervous system or occur because of changes outside the central nervous system, which then lead to sensitization of lymphocytes, which are then able to enter the central nervous system and cause damage by a variety of mechanisms such as molecular mimicry. Now, when we talk about T cells, we're talking about cells that originate in the thymus. That's where the T comes from. These cells circulate in the blood. They're sensitized to an antigen in the lymph nodes or spleen. The target antigen or pathogen is presented bound to one of these MHC, or mixed histocompatibility complex molecules, on the surface of an antigen-presenting cell, which typically is a dendritic cell in the central in the periphery. It can also be a B lymphocyte. It could be a macrophage, or it could be a microglial cell. Co-stimulatory molecules are likely necessary, additional molecules, in order to initiate this sensitization, but they may not be required with cells once they've been sensitized. The differentiation of these T lymphocytes is influenced by the chemicals around them, the cytokines and interleukins, so that they may differentiate into regulatory cells, into pro-inflammatory cells, or into non-inflammatory cells. And how we characterize these phenotypes of T cells depends on the cytokines that they release and surface molecules that they express, which we refer to as CD, or cluster of differentiation markers. And the classical explanation of this, which, as you may have heard this morning, is drawn from the EAE model, which is a powerful model in terms of identifying T-cell immunology, but not necessarily a perfect model of MS, is that these activated T lymphocytes attach surface molecules to adhesion molecules expressed on endothelial cells, which allow them to anchor against the endothelial cells, cross into the central nervous system, where they then may be re-exposed to their particular antigen and activated again, and then release various activators and chemokines which draw other cells into the area, amplifying the inflammation, as well as nonspecific chemokines which attract other cells from outside the central nervous system into the area of inflammation. The local inflammatory reaction results in damage to myelin, oligodendrocytes, and axons by way of expression of toxic molecules, antibody complement-mediated damage, cytotoxic interactions with local effector cells, and various damaging molecules in the microenvironment. The remission of the lesion acutely likely results from the induction of regulatory cells in the area of the lesion and clearance of the damaged debris. Now, B lymphocytes are not important in EAE, but they are very important in MS. B lymphocytes are generated in the bone marrow. They traffic in and out of the central nervous system. They carry CD19 and CD20 surface markers. They can produce antibodies which may act against MS-relevant targets, enhance activation of other cells, and bind complement. They produce the oligoclonal bands that we look for in spinal fluid. They can function as very potent and selective antigen-presenting cells to activate T lymphocytes within the central nervous system. They can act as regulatory cells by secreting cytokines which modulate the actions of other cells. They're found in the meninges, the linings of the brain and spinal cord, in early MS, and more extensively in people with progressive MS, including aggregates which have the appearance of tertiary lymphoid structures similar to lymph nodes. They're found in perivascular spaces associated with deep white matter lesions, and they're thought to be important mediators through soluble factors of damage that's related to damage in the cortical surface as well as the deep white matter. And then we have activation of the innate immune system. Circulating blood, peripheral blood monocytes migrate to the central nervous system and transform into macrophages where they digest damaged myelin. CNS-resident microglia respond to changes in the local environment. Subtypes can have inflammatory, anti-inflammatory, and even repair effects. Astrocytes modulate inflammation and affect the microenvironment. They can release damaging molecules. They can limit damage by taking up toxic molecules. They can influence lymphocyte and microglial activity, and they are important elements maintaining the blood-brain barrier permeability. And then natural killer lymphocytes are immune regulatory cells that are found in blood, brain, and CSF. They're able to kill activated T lymphocytes and may act in immune surveillance. So the emerging concepts regarding immune pathophysiology is that the complexity includes heterogeneity in the functional states of cells that appear similar under the microscope, heterogeneity in pathologic processes between individuals and even in the same individual over time during the disease course, And we know now that inflammatory lesions in the CNS are present in all of the clinical phenotypes and are associated with the severity of the disease course. An article, a pathologic study that just came out last month, looking at over 200 autopsy studies of MS brains, found that even in people at the time of death, they had active inflammatory lesions in their brains, and that the number of those lesions and the occurrence of those lesions could be correlated with their course in life in terms of the rate at which they develop and severity of progression that they developed. We know that adaptive and innate immune cells are in bidirectional communication, and we know that immune cell subtypes may have damaging or beneficial effects depending on the particular microenvironmental setting, which may influence degeneration, regulation, and perhaps the potential for repair. So let me turn to some pathology and pathophysiology. So this is a slide that was taken from an article a number of years ago in the New England Journal of Medicine, and what it shows you is a single postmortem brain lesion. And this is the lesion here. This is the brain segment. This is an MRI, which is done post-mortem of that particular segment, and you can see here an area where there's a plaque. This is the same segment after it was stained for myelin, and you can see that the dark blue areas are more richly myelinated than the light area here. This is a close-up of that same area. If you look at under the microscope, you can see that the plaque is surrounded by these areas where you have these clusters of cells. These are veins, and you can see the inflammatory cells here around the veins. This is a different section, and you can see the vein. I can't see this terribly well, but the vein is somewhere around there in the center of the plaque. Now, what about remyelination? So long as the axon survived, it is possible that remyelination can occur. It depends on the appearance of oligodendrocyte precursor cells, which tend to line up at the edge of the lesion, which is what you see here. And it requires that certain factors be present, not all of which are fully understood, which allow these cells to mature into oligodendrocytes and then to remyelinate surviving axons. It requires the clearance of myelin debris by the phagocytes that emerge into the lesion, the macrophages. And those new sections of myelin are thinner and shorter, and that has physiologic consequences. We also know that even though pathologically MS lesions are classically described by pathologists as having relative axon sparing, that axons are destroyed in the acute inflammatory lesions. This is one of a couple of classic papers that came out some time ago, around 1998 or so. This picture is from one of the papers by Bruce Trapp, which shows the damaged axons in an acute inflammatory plaque. And you can see on the edge here this terminal end bulb, which is part of a degenerating axon. You can see here the green areas where demyelination has occurred, with the red areas representing myelin. It turns out that some of these axons that are affected will die, others will survive, but when they survive through adaptive mechanisms which maintain conduction at a slower rate and at a rate which is less efficient. We know that from functional MRI studies that it's possible for neural networks to expand in order to maintain function, which is one of the reasons why we see functional recovery when we examine people clinically. But yet, there is still some element of residual damage that's occurred because they need more brain to perform these functions. And so there's been some change occurring, and that change, as we've heard earlier today, can be cumulative over time. We know that MS is a gray matter disease. The lesions that we see most easily are the lesions that occur at the leukocortical edge, where we see between the white matter and the gray matter. We see these on conventional MRI. These small lesions within the middle regions of the cortex we don't see except with very high power MRIs, such as 7 Tesla MRIs. And then these lesions that occur along the cortical ribbon, which are associated with those B-cell infiltrates that line the meninges, and which appear to be the result of soluble factors that are released by these cells that either damage the cortex directly or potentially activate other cells such as microglia to damage the cortex. So the pathology of progressive MS is poorly understood compared to what we've talked about regarding relapsing or adaptive inflammatory MS. It involves both inflammation and non-inflammatory mechanisms. It involves continuing damage and failure of repair mechanisms. And it's compartmentalized within the central nervous system, where it escapes many of the actions of disease-modifying therapies that we currently use. It involves both the extension of inflammation at the edges of lesions. We've heard about slowly expanding lesions and lesions with rims containing iron and microglia and macrophages, which are referred to as paramagnetic rim lesions. We've heard about inflammatory plaques which occur within the brains of patients who die with progressive disease. So we know that those elements are there. And there's diffuse lymphocytic infiltration with persistent active lesions and perivenous infiltrates. On the other hand, we also know there are non-inflammatory mechanisms. We know that damage to myelin has an effect on trophic influences, which maintain neurons and axons. We know that there are changes in synaptic density, which are likely mediated by microglia. We know that oxidative stress occurs because of the increased energy that's required to maintain conduction through the damaged segments. And we know that in some cases there's direct exposure to toxic molecules which damage axons and neurons. So when these axons are damaged, they form new sodium channels in order to maintain electrical strength and maintain conduction. However, that requires an active process because the pump that extrudes, that exchanges sodium for potassium requires energy. That results in the mobilization of mitochondria to the area of damage. In some cases, remyelination occurs. In other cases, remyelination fails and you develop astroglial scars. Over time, these plaques, which require increased energy, the mitochondria may change. Mitochondrial DNA changes, and you may get maladaptive mitochondria, which are no longer efficient at developing the energy that's required to maintain conduction. That can result in later damage to these axons, and they can drop out, further increasing the stress on other axons in the same pathways. To give you an idea of how this may influence symptoms, this is an individual who has a common MS symptom called internuclear ophthalmoparesis. And if you look at the top image here, you can see that when he wants to look to the right eye, which is moved by the lateral rectus muscle, which is mobilized by the sixth nerve nucleus, moves to the right. On this particular individual where the arrow is, the left eye doesn't quite get over as much, and that's mobilized by the medial rectus, which comes from the third nerve motor nucleus. The third nerve motor nucleus is up here in the midbrain. The sixth nerve nucleus is down here in the pons, and the center that triggers gaze control is located in the pons as well. And it connects to the third nerve motor nucleus by means of a fiber tract called the medial longitudinal fasciculus. And what happens is that in an individual who has demyelination along that fiber tract, the sixth nerve motor nucleus gets triggered slightly ahead of the third nerve motor nucleus. And so you get this lag between the activation of these nuclei. So what's happened here is the synchronization of functions has been broken up, so that because of the slowed conduction or the altered conduction. And so this sort of paradigm can affect multiple other functions, whether we're talking about bladder, whether we're talking about cognition, whether we're talking about motor function. All right, Clinical and MRI features, very briefly, because you'll hear more about these, I'm sure. Optic neuritis, the most common visual symptom in MS, typically impairs vision. It develops gradually rather than abruptly. It usually affects one eye in MS. When it affects both eyes together, it's more likely MOGAD or NMO. 90% of the time, it's associated with pain, usually evoked by eye movement, sometimes periorbital or retroorbital. It typically recovers over a period of weeks to months, and the recovery in MS is generally good for initial lesions, but it does occur with other diseases. In people who have had optic neuritis, when they experience intercurrent illness, such as with fever, or when they experience heat, for example, during exercise, they may get transient blurring of vision because of the changes in conduction and because the heat activates the speed of conduction, so that you may get disruption of conduction, breakdown of conduction, and so they may temporarily experience recurrent symptoms. This is the mechanism that underlies pseudoexacerbation. When it occurs in the eye, we talk about it as something called Uthoff's phenomena. In the spinal cord, we typically get these small partial segmental lesions, typically involving the dorsal or lateral columns. When you see larger, full-length involvement of the spinal cord over multiple segments, think about other diseases, particularly, again, diseases like NMO and others. Now, there are a number of silent symptoms that occur in MS. Fatigue is probably the most common one, virtually ubiquitous in almost everybody with MS, with rare exceptions. For a substantial number of people, it's their major limiting symptom. And it may occur primarily as a result of MS mechanisms. These may involve conduction block, cytokines and inflammation, increased energy requirements of conduction, expanded neural networks, perhaps others. Acute changes in fatigue sometimes herald new disease activity. And secondary fatigue occurs due to comorbid conditions, deconditioning, sleep disorders, and the effects of the medications that we sometimes use, as well as depression. Cognition. Cognition can be measured to have abnormalities in 45 to 65% of individuals with MS. Sometimes these measurable deficits are relatively subtle, but they can be seen as early as individuals who have radioactive isolated syndrome, radiological isolated syndrome, sorry. Cognitive impact can predict disability independently from physical impairment. Prevalence doesn't necessarily correlate with physical disability. They can occur independently. And the impairment's often not recognized by the patient, but rather by those around them. But it has significant impacts. They're less likely to be employed. They tend to be less socially engaged. They have difficulty making decisions in terms of daily activity, and it may impair their ability to live independently. Depression occurs in 25 to 35% of people with MS, a lifetime history as high as 45%. Up to a quarter of MS patients may report thoughts of suicide, although a minority act on the thoughts. Interestingly, a recent Danish study found that there was no increase in depression in the period from 2000 to 2016 compared to a twofold increase in the 20-year period before that, perhaps reflecting an influence of the availability of treatment and that impact on people's reaction to disease. Some studies have associated depression with higher lesion volume in frontal and temporal regions and with reduction in volume of the hippocampus. And it's one of the strongest factors that affect adherence to medication. Bladder dysfunction, a variety of patterns. Loss of cortical inhibition of the detrusor muscle on the wall of the bladder causes small storage capacity, increased urgency and urgent continence, urinary frequency. Less commonly, insufficient contractility of the detrusor causes a weak bladder muscle, which impairs emptying, so that an individual has urinary retention with increased risk of urinary infection. Loss of sensory input to the micturition center in the pons desensitizes the bladder, so again you get urinary retention because they don't perceive filling as well, sometimes dribbling incontinence. And then detrusor sphincter dyssynergy, where you have incomplete relaxation of the sphincter muscle in the bladder neck associated with a small capacity bladder because of diminished detrusor storage capacity, and that results in partial emptying against a closed, partially closed opening, and typically results from spinal cord lesions. We look at classic MRI patterns as part of the way of defining the diagnosis of MS. Contrast-enhancing lesions occur acutely. Typically, the contrast enhancement has a ring or partial ring or a homogeneous pattern. It typically lasts for 1 to 2 months and then is gone, so persistent enhancement beyond 2 months ought to always be concerning for some other diagnosis. Classical periventricular lesions, these are what are known as Dawson's fingers. You saw a slide just like that earlier this morning that I think Fred showed. Infratentorial lesions commonly occur in the cerebellar white matter or the cerebellar peduncles, the juxtacortical lesions at the gray-white junctions, and the spinal cord lesions, which tend to be partial and segmental. Studies that were done by Henry McFarland and others at the National Institutes of Health years ago showed that if you do MRIs every month on people with relapsing MS, new lesions come and go about 10 times more often than people have symptoms, or even that findings can be detected on examination. And so we know that the MRI is a more sensitive marker of disease activity than clinical examination. And over time, what we see in people with MS is increased loss of brain and spinal cord volume, which is a marker for progressive change at the population level, but less clearly at the individual level because of numerous difficulties in terms of measuring change. So for example, brain volume can change through the course of a day. So the same individual may have a higher brain volume at one time a day, at a lower brain volume at another time a day, how much water they drank the night before. A number of other factors may influence measurements. However, long-term measurements at the population levels have clearly been associated with progression. And particularly in terms of the spinal cord, atrophy of the spinal cord in the cervical regions has been associated with physical disability. We heard this morning as well that even in people with relapsing MS, when we look at when progression appears to occur, studies have shown that most progression occurs independent of periods of relapse. And the way these studies were done is that individuals looked at randomized clinical trials, looked at the populations, looked at the dates. You know, these are regularly measured populations with scheduled examinations, and they looked at when progression occurred in relation to when relapses were recorded, and they found that 75% of the progression in these relapsing trials occurred in periods that were not associated within 3 months of a relapse. As you heard this morning, there may be some differences in how people define PIRA, but clearly the process of progression appears to occur even independently of what we see overtly as clinical relapses. We've heard about some of the new and more sophisticated MRI techniques which can show us these paramagnetic rim lesions, which is what you see here. These are chronic active lesions with a destructive center and a rim of inflammation. That inflammation is largely made up of macrophages and microglia, which contain iron. The iron is likely released by damaged oligodendrocytes. There's axonal transection, and the number of pearls has been associated with the rate and severity of disability, and potentially may be a marker of future progression independent of relapse activity, although as yet that remains to be clearly established. All right. Let me turn to phenotypes and natural history. You heard a bit about this morning. We talk about relapsing remitting MS with symptomatic bouts and variable recovery. We talk about progressive MS with gradual worsening of impairment that's not due to incomplete recovery from a relapse. And then we modify these by talking about activity over a specific time period, which is the presence of relapses or new lesions, or progression, which is the progression of, on a neurologic examination, of change in the absence of relapse. And these cartoons from the MS Society illustrate those patterns. So the natural history of MS, if you look at these cartoons, you see that where the clinical worsening progresses over time, overt relapses diminish over time, and you see that MRI activity, which is these small green arrows here, increases at the beginning and even before the beginning of MS, and this is the period of RIS, and then diminishes over time. And what drives that, we don't fully understand. We have a number of ways of measuring change clinically, the Kurtzky scales, but the Kurtzky scales have limited utility because of the dependence on ambulation and the poor measurement of cognition and fatigue. More additional measurements like the MS functional composite include the 25-foot walk, the 9-hole peg test, the symbol digit modality test to test cognition, and low contrast visual acuity tests. More detailed measures of cognition, fatigue, and endurance uncover deficits that these scales don't recognize, and patient-reported outcome measures give us insight into disease effects that we won't see on a bedside exam. Predicting clinical course is extremely difficult at the individual level. There's a considerable heterogeneity between individuals. This probably reflects individual differences in biologic processes related to inflammation, neurodegeneration, and remyelination. The clinical phenotype descriptors don't capture this, and so the individuals with the same clinical phenotype may have very different biology. There are a number of factors that have been identified as increasing the risk of progressive MS. They're listed here. More attacks early on, higher lesion burden, higher disability at onset, breakthrough attacks despite therapy, progressive onset, older age, male compared to female. We're starting to look for biomarkers. Neurofilament light has been around now for several years. It reflects axon destruction. It can be measured in both serum and spinal fluid, and serum measurements appear to be equivalent to spinal fluid measurements. Changes correlate temporally with relapses and new inflammatory lesions on MRI, but its value in predicting future disability at the moment is unclear. GFAP, or glial fibrillary acidic protein, is expressed by astrocytes. It can be measured both in spinal fluid and in serum. It doesn't increase with relapse activity. It has been associated with disability progression and may be predictive in some studies. But we still have to validate the right metrics and the right fluid source in order to utilize it. And we're starting to see these multi-component protein assays, which perhaps will provide better sensitivity and predictive value for MS activity. Our experience in the current era suggests that there's been a change in the natural history and a mitigation in disability progression. These are a number of studies which have looked at that. Many of them more recently have suggested that the initial use of higher potency therapies is more effective in terms of short-term disability progression. But these changes may reflect multiple factors, not only disease-modifying therapy, but also changes in how we take care of people, changes in wellness factors and changes in comorbidity, the fact that we diagnose people earlier, and the fact that we diagnose people with milder disease because of better technology. Comorbidities are extremely important, and unfortunately not enough time is present to go into them in detail, but mortalities due to cardiovascular disease, infection, and respiratory diseases are increased in MS populations. Vascular disease can be associated with the risk of disability progression in MS populations. We talked about tobacco. Vitamin D probably doesn't associate with progression, but there's some studies suggesting it relates to inflammatory disease activity. And there's a lot of work now being directed at the gut microbiome to see if that can be modified and affect disease activity. So in summary, MS is both a inflammatory and degenerative disease of the central nervous system with diverse pathologic processes that occur simultaneously through the course. We don't know the cause, but both genetic and environmental factors are important and interactive contributors. The pathology involves both white and gray matter, inflammatory cells of both adaptive and innate immune systems, and the mechanisms of progressive MS are compartmentalized. The individual biology is heterogeneous and varies despite clinical phenotypes. And I think I'll stop here, and thank you for your attention.
If y'all have, oops, we're going to escape. If y'all have questions for Dr. Cohen, you can catch him in the hall. Oops. Well, I don't know how to get this closed.
Is ours open on the bottom?
You know how to do it?
Maybe.
Oh, you did it. Are you? Would
you
you
take
do
it
this?
from me.
Touch it?
Yeah.
Okay. Yeah, no, it'll
Where's
come
the
up
file?
automatically. You have to wait.
Okay.
Every time we do this, it's something new. So let me introduce to you Derek Robertson. I've known Dr. Robertson for a number of years, and he, again, is a speaker that has spoken for fundamentals for many years. He is an associate professor and vice chair of the Department of Neurology of the University of South Florida. I'm a Floridian, he's a co-Floridian. He also serves as a director of the MS and Neuroimmunology Division and director of the MS and Neuroimmunology Fellowship Program. He completed his internship and residency at the University of South Florida, and he's been involved in many clinical trials and is someone who has spoken all over the country. So I did want to just let you know one thing. Many of you may know, or you may not, but with permission of the speakers, the slides will be posted on the CMSC website within a few weeks after the program's over. So, Derek, come on.
Thank you, Connie. I appreciate it. Well, good morning, everyone. I was sitting over there listening to Dr. Cohen, and I'm like, how am I going to follow that? Like, what can I add to the story of fundamentals? And thanks, everyone, for coming to this session. I know there's lots of competition, lots of good learning for these next few days. I mean, it got me thinking, when's the last lecture I gave? So about 2 weeks ago, I gave a lecture to the medical students back home, and medical students are terrible, terrible learners. Nobody comes to the lectures anymore. Ever since COVID and everything streamed on Zoom or Teams, there's a 200-seat auditorium that I went to the university, the same one I teach at, that my tuition dollars built this beautiful auditorium, and nobody goes to the lectures. It was me up here and one student in the way back, and the AV guy. So you get the lecture, it gets recorded. Supposedly they're online at the same time listening. I know, because I sit through lectures where I turn my camera off and do not pay attention. And then they listen. I asked them, because I'm like, what's the point of me giving the lecture if nobody's here? They listen to us, for those of us that give lectures. Dr. Cohen, I bet they do this back home for you too. They listen to us on 2 times speed, so all of us sound like chipmunks. So like we give the lecture, and then all of us, when they actually play it back, just sound, and I'm like, I got to go in private practice. I don't want to sound like a chipmunk to 200 people's ears every year. So thank you guys for coming to the lecture. For Dr. Cohen and Connie, thanks again for organizing. All right, so what are we going to learn about? So it's kind of the point of fundamentals, and I think it's such a great part of CMSC, is that it builds on each other. So some of the parts that Dr. Cohen started with, I'll build upon, and it'll be a little bit more clinically focused. Like some of his slides were, it was clinical, and he mentioned, oh, we're going to talk about this downstream. This is some of that talking about it downstream. So that's what I get to ramble on about for the next half hour or so. So we're going to talk about the role of imaging in kind of the routine diagnosis and management, how it's the single best tool that we have to get the accuracy of the diagnosis, whether it be MS or something that can mimic MS. There's a talk tomorrow that's a part of fundamentals that Dr. Lee, one of our neuroradiology colleagues, that he'll kind of dive a little bit further into MRI. So I'll kind of start a little bit of the conversation on how we order it, what it looks like, the different sequences, and then he'll kind of build on that tomorrow. I'll talk a little bit about the MS diagnostic criteria. For those that went to the first lecture with Dr. Lublin, he kind of sneak peeked that there's going to be kind of a new iteration later this year that we'll have to learn. It'll be the 2024 diagnostic criteria, McDonald's diagnostic criteria. Part of that is the primary progressive MS patient population, and then there's a talk tomorrow in fundamentals with Dr. Coyle that'll go over that more in detail. And then I'll talk a little bit about some imaging and patient characteristics on when it's not MS and how we kind of pivot away from maybe inappropriately applying the McDonald's criteria. Here are my disclosures. All right, so we'll start with the case. So we have a 28-year-old woman. She comes into the clinic with a 2-day history of painful vision loss in her left eye, no other prior symptoms, any neurologic symptoms, incredibly healthy, no past medical, family, social history that would take us in another direction. On examination, she has findings that are suggestive of what she has, which is optic neuritis in her left eye, but she also has some other deficits on neurologic exam that we don't have a good explanation for yet. So she has jumpy reflexes on her right arm and right leg. So a full workup, including lots of serologic studies, are done. We send her for MRI, and again, I'll unpack kind of what we're looking at on downstream slides, but she has, can you guys see that? Yeah. So there's a ring-enhancing lesion on the right side of her brain in the subcortex. She has these little areas of white spots on this MRI sequence that's along the surface of her brain, the deep middle parts, different orientation, and I'll explain this in a second, that Dr. Cohen went over, these things called Dawson's fingers. So here we are with this lady. She's in your clinic. She has these symptoms, and she has this MRI, and now she's coming back for her first follow-up. Do we already know her diagnosis? Does she have CIS, or clinically isolated syndrome? Does she meet the McDonald's criteria? Does she have clinically definite MS? Does she have something else that's mimicking MS? Or, always my favorite answer, do we need to do more stuff? Do we need to do more testing to get to the diagnosis? What brave soul wants to take a shot? There might as well only be one of you in the audience if no one's going to guess. I heard a vote for D. I always like D. D's such a good one. Because, again, that's how we stay in business, right? We put them for a follow-up, and they order more tests. Mm-hmm.
And she has multiple lesions. So I feel like it's definite.
We have a vote for definite. It is. She has definite MS. And so I'll explain. Good. You can leave. You don't need to stay. You're getting. So I led with this case so you could see kind of what a layup with Dr. Cohen and Connie, us, we're in clinic. We see this patient. We tell them they have MS. Then we talk about what to do next, but she meets the diagnostic criteria for the disease. So again, and it's still a clinical diagnosis. We use all these appropriate paraclinical tools to help us get to the diagnosis, but an appropriate history is the most cost-effective thing we do as clinicians, is talk to our patients, unpack the symptoms they're having, and if they have these typical clinical presentations, optic neuritis being one, he mentioned one in the other talk about spinal cord presentations, the INO, that weird kind of eye finding that he was teaching us, all those are kind of typical syndromes that the patients can report as symptoms, and we can see on examination, and then we use MRI along with potentially lumbar punctures to kind of marry it all together to meet the diagnostic criteria. So MRI still is the most important both diagnostic and prognostic tool that we have. There was a really good talk that I sat through yesterday on MRI, Dr. O and Dr. Trabilsi and Dr. Lee, who's a part of Fundamentals too, did a really good job kind of talking about kind of the newer MRI techniques that all seems like is going to be incorporated into the diagnostic criteria, which I'm really excited about. But we have to look at our own images. When I'm back home teaching our docs in training, the single worst thing we can do is just rely on a radiology report. And that isn't a knock to the radiologist, but they didn't get to do the most important part. They didn't get to talk to the patient to see what kind of symptoms they have, to then think about, well, where would I expect there to be inflammation on a brain scan, on a spinal cord scan. So looking at your own MRIs and not relying on the radiology report is so important when you're a clinician, when you're taking care of the patient. I have no idea if this, I just stole this from Google. I don't even know if this is actually MRI physics. It just looked interesting. But here's what I know about MRI, and I've had this explained to me, and it really stuck. It's in stone in my brain now, is that human body is made up mostly of water. Water molecule has 2 protons, right, the hydrogen. And those hydrogen ions, when they spin, they give off a noise that the MRI machine is basically just a big recording system. So it's learning or hearing, for lack of a better term, that pulse from the hydrogen ions. So the hydrogen ion that's in spinal fluid is different that's in the vitreous of the eye, that's different in the brain tissue, or that's white matter, that's different than it's in gray matter. So that image that gets constructed that we then look at is just that. It's the spinning of that hydrogen ion. And again, maybe that equation up there is talking about that, but that's really, because patients never want to go for the MRI. They're annoying, they have to lay still, they're claustrophobic, they're expensive, but it is such an important tool for accuracy of diagnosis and monitoring disease over time that this is kind of one of the ways you can explain that loud banging noise that the patients get annoyed by when they're sitting there. Well, that's the MRI machine hearing, the magnet spinning around the body, kind of listening for those hydrogen ions. Again, it's good for soft tissue, excellent resolution, no radiation, so different than CAT scan that way. But it's slow, expensive. There are certain patients that can't have them if they have implantable metallic devices. And again, the claustrophobia is a big one. I'm a huge proponent of benzodiazepines for these patients. Short course, you're not going to make anybody addicted, but a dose or 2 of Valium to get through an MRI, particularly if it's an MRI of the brain and spinal cord when they're in the machine for an hour and a half, is so helpful for patients. It's measured in this thing called Tesla. The majority of our community MRIs are going to be somewhere from 1.5 to maybe as high as 3 Tesla. So a good 1.5 Tesla that's a newer technology, actually can still give a pretty detailed picture of an MRI. Open versus closed. Closed really isn't closed. It's just the magnet is a little farther away from the person, and that degrades a little bit of the image quality. So we really want to try to convince our patients to get closed MRIs. I'm sorry, open is a little farther away. Closed MRIs, which is where the magnet is really, really close to the body. And again, typically speaking, the higher the Tesla, the more clear the picture. So I'm going to have to change this slide for next year because this is kind of the standard MRI protocol for MS patients. So when we send our patients to get kind of either their first MRI and we're concerned they have MS, or if they have an established diagnosis of MS, here are all the different sequences of what is often included in an MRI pack. Sagittal means the person's pictures are going to be cut kind of from ear to ear, so it goes left to right. Axial is this sequence, so it's from your feet to your head and back, so it's kind of cutting the human body this way. Coronal cuts from like the nose to the back of the head, so it goes back and forth. There's a pretty good argument to be made over the last handful of years at our yearly conferences that we should be giving less and less contrast material for patients over time if we're just monitoring how their disease is going, and that we can learn most of what we need to learn about their disease mostly from T2 sequence MRI. And again, I agree with that. And so in our clinic, we've really done, I think, a pretty decent job at convincing patients that they don't need to have so much exposure to contrast, remembering when we're actually ordering the test not to reflexively order it with contrast, because it doesn't usually help us in the routine monitoring of patients. So, and again, I think with the new diagnostic criteria that comes out later this year, I think there'll be more of a heavier emphasis on non-contrast and maybe some of these advanced metric MRI techniques. Okay, so what is a UBO? So lots and lots of people have these, and I didn't say patients on purpose, just people. Like if we live long enough, we're probably all going to develop something that causes a little scarring on our brain, a little spike in our blood pressure, if we start to develop diabetes, or if our cholesterol runs a little high. So that little tiny dot that's right there, that's the red arrows pointing at, is incredibly common. If you order enough MRIs on enough people, you're going to find these things. So the oldest study I could find, I scoured the literature because I wanted to know, well, how long have we known about these things? So MRI technology really is relatively new. It's new over the last 40 to 50 years. And so I found a study that was from MRIs that were done in the early 80s. And so think about the technology of what that MRI was probably looking for. Probably wasn't that clear of pictures to begin with. And even then, on really, really old kind of beginning stages of MRI technology, published in the late 1980s, we were learning that these are pretty common to find, that people, again, not necessarily patients. These are asymptomatic volunteers that are in their 30s. About 1 in 9 of these people, again, not patients, people, had these unidentified bright objects. And the older patient population, again, people population, so people under the 70s, no neurologic diagnoses, had on MRI brain scan these UBOs on that older MRI technology. I found a newer-ish one because I wanted to know, well, what if they have headaches? We know chronic headache disorders, migraine specifically, also can leave behind these UBOs, and it was approaching 100% of patients that have a chronic, either migraine or chronic headache disorder, they have these UBOs, and that makes our job tough because MS causes these UBOs. But here's the good news. It causes them in very specific parts of the brain. And so I want to show kind of what that looks like. And the diagnostic criteria that, again, that's getting refreshed continues to hammer home these kind of specific areas of where MS lesions happen. They happen next to the ventricles, called periventricular, next to the cortex, or actually the cortex itself, that's juxtacortical or cortical, kind of below the tentorium, so in our brainstem and our cerebellum, and then a continuation of our brain, the spinal cord. So a patient has to have 2 of these 4 areas to have these typical areas of lesion formation to meet the dissemination in space component of the diagnostic criteria. Here's what a periventricular lesion looks like. So this is a T2 flare axial sequence. So the back of the person's head would be here, this would be their forehead. This black here in the middle gives the brain structure. It's the lateral ventricles. And so next to the ventricles is periventricular, and it kind of radiates away. At Dawson's fingers, as Dr. Cohen mentioned earlier, that's kind of what that would look like. This is, again, different patient zoomed in that shows, again, kind of it's radiating away. Why they happen in this area is the specific in this case, venular inflammation. So the vascular tree, right? The heart pumps blood away in arteries, the arterioles, the capillary bed, the venules, and the veins. So of the vascular tree, the part that's the leakiest is the capillary bed and the venules, and so that's leaky on purpose for oxygen exchange, glucose exchange, but that's also where these inflammatory immune cells that want to cause damage to brain tissue, that's where they can leak out. And so why this happens, this cartoon I stole, I probably should tell him, I put it in the talk. Hopefully I remember next week, because I stole it at his lecture because I like it. So there's these little tiny venules that are draining away from the lateral ventricles, and it creates this kind of bubbling phenomena. That's why, and it's called perivenular edema. And if enough edema happens and then the demyelination occurs, then that can lead to axon damage, and the patient now has a kind of a permanent Dawson's finger or periventricular lesion that we can see on MRI. And this is what it looks like on Gross pathology, and again, right next to the ventricle. So that's the first area. The second area is in the subcortex, or juxtacortical. And so this is a patient that has kind of this like Pac-Man looking appearance, where it's the lesion kind of is around the cortex. The cortex is this thin layer that is on the surface of the brain. It's gray matter. It's actually where kind of the nerve starts, and then it becomes myelinated and goes wherever it's going. So that's, again, what a juxtacortical lesion could look like. Here's what a cortical and juxtacortical lesion look like. Now the patient has been kind of stood up with the MRI software, and this would be their eyes, their forehead, their nose. So they're kind of looking, in this case, towards me, or away over there. And so right along the surface of the brain, this kind of larger, ovoid, circular-shaped lesion, that's what MS looks like on MRI scan. That's the second of the typical areas where it can occur. This is showing actually lesions inside the cortex on gross pathology. Here, it's again along the surface. All right, so the third place is infratentorial. So this is, again, actually the same patient of mine, a little further down. You can't see it on this sequence, but you kind of can. But there's this thin membrane that separates the top part of our brain, called the supratentorial region, from the bottom part of our brains, called the infratentorial region. And so there's so many tightly packed axons that this is another area where MS can happen, and it has that same kind of often ovoid or circular appearance, but it's in the bottom part of our brains, the infratentorium. So that's the third area. And then lastly, this is spinal cord. So this is kind of zoomed in. So the brain would be up here where the word spinal is, and then the continuation of the brain is the brain stem, and then now on down is the spinal cord. These are the bones, these are the vertebrae, the discs. So this gray stripe should be nice dark gray all the way down, but where there's areas of white is lesions. These are not supposed to be there, and just like we get lesions in the brain, some patients can get lesions in the spinal cord. Again, Dr. Lee will mention this fundamentals tomorrow, but kind of where they happen, they're a little faint here, but the back part of the spinal cord, so this is now the patient's flipped, laid back down with the software, so that kind of ovoid area there, there's an ovoid area there. Those are kind of the typical dorsal or back part of the spinal cord, or the lateral part of the spinal cord is where MS lesions are more kind of topographically likely to occur. And then in the initial workup of the diagnosis of MS, we absolutely should give contrast. And this is what we would be looking for and what we hope we don't see, but it is helpful in kind of aiding in the diagnosis, is that patients can have these areas of active inflammation. And what that's teaching us is that there's breakdown of that blood-brain barrier. So kind of that leakiness, the inflammatory response is further degrading the blood-brain barrier, and the contrast, which was supposed to stay inside of a blood vessel, is now leaking a little bit into surrounding brain tissue. And this patient was in a world of trouble. All of these were some were causing symptoms, some weren't, but this person was having a multifocal inflammatory disease, and in this case, it was multiple sclerosis. All right, so the current diagnostic criteria we're operating under is still the 2017 diagnostic criteria, and some of the tweaks from it compared to the one before that, which was about a little less than a decade before it was refreshed, was kind of a further re-emphasis on the use of spinal taps. I'm a pretty big proponent of doing spinal taps in the workup of MS. Not every MS neurologist that sees patients is, because of how much MRI can be valuable and in fact diagnostic in the right clinical scenario. I just think it's helpful, potentially even for prognosis. There's some good studies out there that looks at how much oligoclonal bands, that's one of the markers that shows up in spinal fluid, that there's at least a rough correlation that the higher the inflammatory response in the spinal fluid, it might portend a higher level of prognosis, or worse level of prognosis for patients that have those higher inflammatory OCBs. Again, it's not a one-size-fits-all, but it can aid in the diagnosis, and it has some potential prognostic value. So I try to talk our patients when we're working them up into doing it. Not everybody goes for it, and if they have a slam dunk MRI and the right clinical syndromes, they don't need it to meet the diagnostic criteria. And again, you can see a couple other things there, and then tomorrow Dr. Coyle will teach us about primary progressive MS in a talk in and of itself. For time's sake, I know we're running a little behind. I'll skip over this. This is the diagnostic criteria. I highly doubt it'll be that much different here in a few months when the criteria is refreshed, but there's all these different scenarios that you'll need further evidence for to kind of get to a diagnosis. Again, these are open-ended questions. When you're working a patient up for the diagnosis of MS, should they all have CSF analysis? My vote would be yes. Patients often vote no. Other docs that see a lot of MS patients sometimes also can vote no. I think there's a pretty compelling case when you're first working a patient up for MS to look in their spinal cord, to send them for MRIs of their spinal cord, even if there's not a worry based on their symptoms, talking with them and getting a history that they have spinal cord symptoms that predates it. Again, it can help with, there's some prognostic value there to be learned, that if they have spinal cord involvement or at the time of diagnosis, these are often the patients we're a little more worried about, that they have a higher chance of disability in the coming years to decades, and that might influence our decision on what treatments to recommend. And so again, I think there's a decent argument to be made that it should be a part of every kind of the part of the diagnostic workup of somebody that you think could have MS. There's lots of things that would make us pivot and kind of move on from the potential diagnosis of MS, and this is still, I think, holds up kind of a good kind of peek behind some of the signs and symptoms that should kind of worry us that maybe we're leading leaning too much in to an MS diagnosis. So things like polyarthralgias, polymyalgias, that's not a common complaint of somebody with MS, or it shouldn't be. And that should make us think of other more systemic autoimmune diseases like lupus or Lyme disease, headache and kind of chronic neck pain. Again, also not a typical symptom, I would say, of that was from MS. If somebody has an abnormal MRI scan and that's their presenting symptom, that would worry me that we're dealing with something a little bit more sinister, like cancer, like glioma or lymphoma. Large brainstem lesions. This would make me think of, again, scary things like a brain tumor, like Pontine glioma, other immune inflammatory vasculitic processes like neuropochettes, MOG-associated disease, neuromyelitis optica spectrum disorder can give these like really funky, big brainstem lesions. Loss of hearing, definitely not an MS symptom usually. I would think more of something like Susac syndrome. And then other areas of the brain that could have a genetic potential for disease, something called CADASIL. There's typical MRI findings that are associated with that. Here are some more of the kind of specific mimics. And again, there's a whole talk tomorrow unpacking MRI and mimics and that. So this is just a couple of kind of quick hitting things that would enter our brains when we're working a patient up. So 35-year-old African-American woman, she comes into the ER with over a 24-hour period of developing acute weakness in her arms and legs. She has a prior history of acute painful vision loss that affected both eyes 6 months before that. That gradually got better with IV steroids. Again, otherwise healthy lady. If I remember right, I think she worked at Target. She's like 42 now. This is like 7 or 8 years ago. Born and raised in the US, no relevant family history. This was her MRI from 6 months ago. So it showed, so this is the optic nerve, tracks from the back of the eye all the way down, and then it connects together in something called the optic chiasm. And so there's enhancement at the back part of her optic nerves and then where they connect. And again, this is what thankfully got a lot better after steroids 6 months ago, and now she's in a world of trouble. So there's this, and Dr. Cohen mentioned this briefly in his talk, but there's this longitudinally extensive area of inflammation spanning most of her cervical spine. So again, her brain would be up here, the top of the slide, and then this gray stripe should be nice and dark gray all the way down, and it's not. So there's all this edema and swelling it's inside the spinal cord. So she had a workup, including that MRI. She also had a spinal tap. There's markers that show up that are more suggestive of MS, things like oligoclonal bands, elevated IgG index. Those are overreactive immune markers that are more suggestive of something like multiple sclerosis that are unlikely, they can be, but they're unlikely to be seen in somebody that has this condition. She was positive for aquaporin 4 antibodies. She has NMO. She has NMO spectrum disorder, a seropositive NMO. It is absolutely a distinct disease. We have now, thankfully, 4 FDA-approved treatments that are hyper-specific for this pathology on what causes this disease. But there's a lot of similarities. There's overlap. It's also very female-predominating disease. It starts often in the same age ranges, 30s, early 40s. There are some differences, though. It's a much more disabling attacking disease. So patients get really bad optic neuritis attacks, really bad spinal cord attacks. My patient, that's what happened to her. MS, like we went over, much more widespread areas of damage compared to NMO. Thankfully, NMO is much, much more rare, probably in the neighborhood of 15, maybe 20,000 people in America. And as we learned this morning, it's almost 1 million people, probably over 1 million by now, of those that have MS in the United States. So there's a significant difference in prevalence and incidence. But again, there are overlaps on kind of their clinical presentations, women that get it more than men, and again, rough, similarly age ranges that it can start. So here's something, and again, there's going to be a good pediatric talk in a minute, but here's something that can happen in kind of the pediatric into young adulthood age ranges. It can happen older than that, but if you see a patient that's 20 or 21 and they have kind of widespread neurologic inflammatory disease that's affecting their brain and spinal cord, could potentially be this condition. It's called ADEM, or acute disseminated encephalomyelitis. This is a disease that's evolving because it's not a great standalone diagnosis. It needs a reason why it's happening. And sometimes these patients do go on to have kind of a more standard relapsing remitting course, but they often can be monophasic, so it's just kind of the first time bad occurrence. It's been described for years and years and years in medical literature of being maybe after a vaccine exposure, a post-viral phenomena, overshoot of the immune system. So again, MOG-associated disease now has been clearly the culprit in some of these, particularly in the pediatric population and to young adulthood, that when patients have this widespread inflammatory disease, that we should go looking for causes that are diagnosable and treatable, because again, this is kind of like an umbrella term that doesn't talk to one specific disease. But it looks a whole lot like MS. And so this is, again, a patient of mine has, this blushing, that's that contrast enhancement. She had kind of typical inflammatory lesions that are ovoid, around the ventricles, around the cortex. So it looks a whole lot like multiple sclerosis. Here's another patient of mine that I completely messed up for a while and inaccurately diagnosed with MS. And it turned out they had lupus vasculitis, but they had kind of this flavor of looking like Dawson's fingers and juxtacortical lesions. But during one of her relapses, when I had her on an MS therapy that clearly didn't help her, she had a stroke or she had a vasculitic lesion. So this is a particular type of MRI sequence that looks for acute ischemia that, again, MS patients sometimes can get, but it's not commonly seen, like a DWI, a positive lesion, and that kind of led us to pause the diagnosis of MS, reopen our thought process, and she was ultimately diagnosed with lupus, changed her therapy, and she's doing much better now. But again, this diagnostic conundrum of just relying on MRI, because I've put this MRI up, and it looks a whole lot like MS. There's some haziness, there's some other parts of it that really should have raised my index of suspicion to go a different direction, but she didn't have MS. So this would be our last case, because I know my time's almost up. So a 39-year-old man, history of relapsing MS, on natalizumab for 4 years, comes in an ER having a witness seizure at home. For the past few weeks, there's been a behavioral change. His wife said he's just not the same. He's very hot-headed, throwing things around the house, way out of the norm for him. He only has a history of multiple sclerosis. So we got an MRI on him, and he had kind of the typical MS lesions back here, but he had this huge area of kind of fluffy, infiltrating T2 signal change on the front part of his brain. And if you've learned nothing about me rambling on for 30 minutes, that is not what MS looks like. That big area that I circled in red, this poor guy had PML. He had progressive multifocal leukoencephalopathy. It's caused by widespread infection of the JC virus, first described in HIV patients. It's an opportunistic infection in somebody that's immune compromised or that has an immune compromised state. In this case, kind of an immune privileged area of the brain already was further immune privileged by the therapy that he was on. There's a whole host of MS therapies that have this potential risk, natalizumab being by far and away the most concerning. We thankfully have a blood test that we can screen patients for. I should mention, this is not a real patient. I had to make this one up because I thankfully have not seen this in our practice. I didn't want to lead with that. I wanted to make it seem real because this does absolutely happen. There's well over 1,000 patients now that have had natalizumab-induced PML, and it's avoidable by and large with patient selectivity, screening patients with blood tests that sees if they have this past exposure to the JC virus and perhaps not using that class of medications that have that risk in patients that are JC virus antibody positive. All right, so my last couple slides, and again, Dr. Cohen briefly mentioned this, and it's kind of building upon it, is kind of what is this natural history of MS? Dr. Lublin did a good job kind of recapping this in our first lecture, our joint lecture this morning. So radiologically isolated syndrome is kind of a preclinical phase. I know this is a busy slide, but so these black lines are inflammatory disease that are showing up, these black arrows, on MRI. So before somebody actually has new symptoms that drive them to the ER, to the clinics, to their primary care doctors, to us, there's a very clear prodromal phase that if we can capture on MRI. If somebody gets into a car accident and they get an MRI in the ER, we see this sometimes. We see it probably once a month. We follow, a few dozen patients in our clinic that have this condition, and then we follow them because some of them convert into relapsing MS. And how we define that, who's at risk for it, there's been some pretty good RIS kind of history studies that observationally looked at kind of who is at risk to transition into actually having symptomatic disease. They have relapsing remitting disease. About 10% of patients can have more of a primary progressive course. If they start with their first attack, that's CIS, that's clinically isolated syndrome. So again, RIS is, I'm really interested in this because this is how we can help the patients the most, is by identifying before they become too symptomatic. How we go about doing that, who we should screen, do we screen family members? The answer is nobody knows. But this is a very real thing, and this was, I think, still to this date, the best study that followed the highest number of patients that tried to prognosticate who was at risk of getting this condition. So it was close to 500 patients. They were followed for almost 5 years. It was kind of a pulling together of a bunch of different databases from multiple countries, and about a third of patients in that 5-year time period that had this radiologically isolated syndrome. They had MRI evidence of MS, but not clinical symptoms yet, went on to develop their first attack. So they either had CIS at that point or a kind of a longer-term form of multiple sclerosis, and it was about a third. So there were some risk factors. If you were a man, it was more likely to convert. Younger age at finding RIS. The presence of spinal cord lesions, you were more likely to convert into an inflammatory disease at that point where you actually knew you had it. Again, clinically isolated syndrome, we talked about this, optic neuritis, brainstem lesions, spinal cord damage. Those are the typical ways somebody starts with MS, but if they don't meet the diagnostic criteria for MS yet, they often fall into this nebulous, clinically isolated syndrome bucket. Then I think my last slide is Dr. Lublin, who gave us a talk this morning. It's kind of the building upon of what he said about how we define these patients. So now, as we kind of enter the age of developing therapeutics for progressive disease, we have to know and enroll patients in studies that are at risk to have a problem happen so we can see if the treatments work on that type of patient. And so that's what kind of coming up with better disease modifiers is so important, because if somebody has a very mild, stable form of the disease, that isn't the kind of person we should enroll in a clinical trial, because we won't see a treatment effect because they'll just keep on being stable. And so the point of these modifiers was to do a better job at helping with prognosis on individual patients or population of patients that we follow, but also as kind of a peek towards, well, how can we help the ones that are progressing? Because it is unacceptable for patients to have inflammatory disease now. If a patient lands in our clinic and they have had their first time relapse, the expectation should be they should stop having relapses. We put them on therapies, we match them up to one that can help. That should be our treatment goal. The trickiest patient population to treat is on this slide, is the patients where maybe we've done a good job at preventing ongoing relapse, but they're still having this PIRA, or progression independent of relapse activity, and that's kind of baked into these modifiers, is to identify those patients and then come up with therapies that could treat what's driving that PIRA, that progression independent of relapse activity. And Connie, I am way over. I apologize. So there are many diseases that can mimic MS. There's a whole talk tomorrow on fundamentals on it. MRI is by far and away the most invaluable tool for both diagnosis, ongoing management of MS patients. And then again, those mimics, learning kind of those red flags on when to pivot away from the diagnosis is important. So I will stop there. Thank you, everyone.
Oh, I don't know.
didn't miss anything last night. It was okay, but. Okay, I think we're going to get started. Our next speaker is a friend of mine from Birmingham, Alabama. Yolanda Reeler is an assistant professor and nurse researcher at the University of Alabama at Birmingham in nursing. In addition to her duties as professor at the nursing school and various research endeavors with the U.S. Network of Pediatric MS Centers, she has been a nurse practitioner at UAB Center for Pediatric Onset Demyelinating Disease for nearly 18 years. She doesn't look that old, but been there a long time. So she works with the children and the families and other demyelinating diseases like MS. She's a longtime volunteer and patient advocate. She has done work with organizations like the MS Society and the Multiple Sclerosis Association of America, as well as Can Do MS. So any of you that don't know what Can Do MS is, see one of us, because they're a very talented group of people who travel around the country and do assessments of patients. So Yolanda is coming to talk. This is our only hour that we do pediatric MS. I think there may be some other pediatric here. I haven't seen it on the agenda, but she's going to talk to us about the treatment and management of those young people to adulthood, or as they transition to adult care. Okay, come on, Yolanda. You got your little thing here. Did you get your own slides up? You didn't want to see me fumble around the computer. Okay.
So they asked me to do this talk in an hour. How do you crunch 18 years of your life in an hour and decide what to talk about, and how pediatric MS has shaped my whole life, I feel like, as a nurse practitioner and as a researcher. We'll start off by, let me make sure there we go. I have my list of objectives here. The only disclosure that I have is part of my salary is funded by the National MS Society through an infrastructure grant that I've been on since 2006. But our objectives, we'll talk about a rare case of pediatric MS in a very, very young patient. We'll talk about the diagnosis, treatment, and management of pediatric MS. I'll also describe unique challenges that pediatric MS patients face, and then I'll explain the need for transition of care, which is another high interest of mine with regard to taking care of patients. Going the wrong way, Yolanda. So, of course, I got a lot of stories I could tell, but I combed the literature when I was first approached about doing this pediatric MS talk, and there was a case that was reported at Cleveland Clinic. They had gotten a consultation for a second opinion for a patient, child that was 2 years and 1 month of age that had presented. They had presented originally at an outside hospital, and this child, of course, was presented with only the symptom of ataxia, and she was admitted to this outside hospital, not Cleveland Clinic, but admitted to this outside hospital. An MRI was obtained. She had some bilateral white matter lesions in her cerebellum. She had other white matter lesions in her periventricular area, and they ultimately diagnosed her with ADEM. And may I add, she did not have any encephalopathy. And so they gave her that diagnosis of ADEM without the presence of encephalopathy. And if you haven't heard that in any of the talks that you have been to so far, ADEM is not ADEM unless you have encephalopathy. And so they did a workup, ophthalmologic workup, they did spinal fluid workup, all of that was negative, but they went ahead and treated her with high doses of steroids, and also gave her a 6-week taper. Then, at 2 months and 4 months, she presented again with similar symptoms to that of her initial presentation, ataxia again. She had some resolving white matter lesions, but she also had some new white matter lesions in her periventricular region and paracolossal and the cerebellar white matter lesion that were demonstrated on MRI. Again, they did spinal fluid. It was normal. Her spinal MRI was normal. They again treated her with high doses of steroids, and she also got a long steroid taper this time because they were thinking that she never fully recovered from the first relapse. And her exam was essentially normal with both of these presentations. And I keep going the wrong way. Then 7 months after the initial presentation was when Cleveland Clinic got the call for the second opinion, and they did another workup. She had another MRI, and at this time, her MRI looked very classic for multiple sclerosis. She had a spinal cord workup, which was negative, but her CSF revealed elevated myelin-basic protein, but was negative for oligoclonal bands. So at this point, they basically declared her relapsing remitting multiple sclerosis. I will share with you a story of my patient that was presented with a tumor-factive lesion at the age of 2, and she was diagnosed with a pediatric stroke. She never had another relapse for 10 years. And then at year 11, as she was going through puberty, she started having symptoms very classic for MS, ataxia, problems with vision, blurred vision, and had an MRI. And that's when she had probably 40+ lesions, and she was de-diagnosed with pediatric stroke and diagnosed with multiple sclerosis. Pediatric MS is rare in individuals under the age of 18. It is thought and estimated that about 5,000 individuals in the United States are diagnosed with pediatric onset multiple sclerosis, about 10,000 worldwide. Data suggests that about 5% of the adult cases in the U.S. are thought to occur before the age of 18. I've talked to a lot of patients over my years working in the realm of MS, and I talk to a lot of young adults, and they'll say they had symptoms before they were diagnosed around their 18th birthday, but they were never suspected or never thought of having multiple sclerosis. Is very less common in that child like I described in my case study that I just presented under the age of 11. 98% of the pediatric MS patients have a relapsing remitting form of MS, unlike those compared to the adult population at 84%. Relapses appear to be more frequent in the pediatric patient when they're initially diagnosed, more so than the adult onset patients, and they typically have a slower progression to disability. I work in a center that was one of the original centers, 6 centers of excellence, pediatric excellence, that was funded by the National MS Society. Since 2006, there have been 6 additional centers added to our network, along with about 9 other affiliated pediatric MS centers. And there have been over 24 studies on environmental and genetic factors that may influence the risk of pediatric MS. They include exposures to viruses, vitamin D deficiency, secondhand smoke, familial history, puberty onset, obesity, gut microbiomes, and air quality. And most of these studies have shown the very similar information that has been shown in the adult population. Diagnosing MS can be very challenging in the pediatric population. Typically, the attacks are optic neuritis or transverse myelitis, although we do have a lot of patients that present with brainstem syndromes, we have a lot more mimickers in the pediatric group because the younger they are, the more they're likely to have other things like leukodystrophies that may mimic multiple sclerosis. We have those antibody syndromes such as NMOSD or MOG antibody disease that have come along in the past decade that have added additional lists onto the things that could possibly have to be ruled out with regard to pediatric MS. Then we have monophasic acute disseminating encephalomyelitis, or ADM, that may or may not be an indicator for pediatric MS, but has to be ruled out. If you have a child that has progressive disease, it's probably suggestive that it is not the diagnosis of pediatric MS, so make sure you understand that. MRI appearance. With regard to lesions, the lesions are more inflammatory in nature. They're more diffuse and less demarcated in the very young patients that have pediatric MS. They're typically asymmetric, just as you would see in the adult population. The classic MRI appearance in the adolescent and teen is just like that of adults. There are more T2 lesions, as I said earlier, in MS onset in children, especially in the brainstem and the cerebellum areas. So diagnosing pediatric MS. There's a international pediatric multiple sclerosis study group that was formed across the world, and they have reconvened on several times and tried and made an attempt to modify the 2017 criteria. All the criteria is actually, and this group convened, and in 2012, they modified all the criteria that have been used over the years for the diagnosis of the diagnosis of multiple sclerosis. And if you look at these guidelines that are posted, you'll say, well, what's the difference? The difference is they added the component of ADM into that diagnostic criteria. They wanted clinicians to make sure that in the face of ADM, there was time in between clinical presentation before or after an ADM attack that clinicians should consider before they actually start considering that a patient has multiple sclerosis when it's being diagnosed in the pediatric area. So we still have the criteria of dissemination in space and time, but it also adds that component of ADM and making sure that it is clear that the ADM is separated from the next attack. I'll tell young residents that I'm training when I'm working in the clinic area, the devil is in the detail. And these are the things that I not put on the slide because I didn't have enough room for my hour talk. Gathering a good medical history, because you will not believe that you will show up and with the patient and you're gathering a history of a patient and you're talking to a teenager and they reveal to the parent, oh, I couldn't see for about 2 weeks ago and I didn't say anything because I wanted to drive my car to school. I was blind in my eye for about 2 weeks. Or a year ago, they were having an event that they didn't want to miss, and they were having difficulty with hand grasp for a couple of weeks, and they didn't say anything to their parent, and the parent is sitting there with their mouths open because they're like, I didn't know about that. So the devil is in the details, gathering a good medical history, making sure you're talking to the teenager, which is typically teenagers that are being diagnosed around 14, 15, 16 years of age, making sure and sometimes you have to dismiss the parent out of the room because you may get more information when the parent is not there because they're in trouble because they've been driving with one eye. And so making sure that you gather that important history so that you can meet that criteria, whether it is dissemination of space and time. The MRI will tell part of the picture, but you need to gather a good history. Treatment options for pediatric MS are very similar to that of the adult population. We use high-dose intravenous steroids as well as high-dose oral steroids. How many of you all use high-dose oral steroids in adult patients? So that was something that was very interesting in the pediatric population. We have a neuro-ophthalmologist at our center close to us, and he typically uses the steroid slushy, he calls it. It's pretty gross. I have tasted it. I do taste all the medicine that I prescribe to my patients. It's pretty gross. It comes with a lot of side effects, but it keeps the patients in their social space, so they don't have to be admitted. They don't have to miss a lot of days of school. So we do use that on occasion. Normally, if a patient uses oral steroids one time, if it's a slushy, they don't want it again. Normally, if you're calling in high doses of steroids, especially if it's 1,000 milligrams, you have to call the pharmacist ahead of time and tell them, because they're like, is she crazy? She's calling in 50 tablets that have to be taken at one time. And so you usually have to call the pharmacist ahead of time and let them know what and why you're doing it, because they may not fill the prescription. Then we use immunoglobulins and plasma exchange if there's no or little recovery with the high doses of steroids. And we also do the very things that most typical of adults, doing symptom management, referring them for a specialty if they need to go for bladder issues or any other things that they may deal with when it comes to symptoms that are secondary to a diagnosis. Chronic treatment, the only FDA-approved medication in the pediatric population is fingolimod. Out of the 25-plus generic and name brands, and all the years that I've been taking care of children with multiple sclerosis, we only have one FDA approved. So all of our drugs are used off-label. Treatment is site-specific, and you probably have something different in your app, but treatment is very site-specific. For myself, I work at in Alabama. The majority of my patients have Alabama Medicaid, and Alabama Medicaid will pay for rituximab, which is a biosimilar. And I use rituximab. I use whatever the insurance will pay for. If my patients have commercial insurance, I will go for the higher efficacious drugs like ocrelizumab. For those patients who have other commercial drugs, we have to just see what is on the formulary. It's usually a big fight with trying to get medications for pediatric patients. You're going to have to do a prior authorization. You may have to do a couple of peer-to-peers. You may get a peer-to-peer that's caring for, that's OBGYN that knows nothing about multiple sclerosis in general, let alone in pediatrics. And so we're on the phone having a fight with them about medications that need to be suggested. Then I have my outlier patients who have commercial insurance, who make a lot of money, and the parents have high incomes, and they have these policies that require higher co-payments and deductibles. So they might be paying $5,000 co-payment every time their child gets a medication. And, you know, $10,000 is not a small amount of money to come up with for a medication. And so fighting with the insurance companies to get medication approval is one of my big issues with pediatrics. You have clinical trials that have been done in the pediatric population. Trials that have been completed are the natalizumab trial from 2015. They enrolled about 400 participants. Then you have the interferon beta 1b. Both of these studies were retrospective observational studies, and they had 307 participants, but yet and still, neither one of these drugs have been approved in pediatrics. I want you to note that. Then you have a couple of ongoing trials that are going on right now. Ocrelizumab versus fingolimod. It's a phase 3 interventional randomized double-blind, double-dummy trial called Operetta 2 that's going on. They are recruiting still for this particular study. Right now they have 171 participants. that have enrolled in these studies. And if you notice, the numbers for these studies are very small in comparison to the studies that have been done and conducted in the adult population. Then you have ofatumumab and siponimod versus fingolimod. It's a two-year randomized, two-arm, double-blind trial with open-label extension that's going on right now. It's the NEOS trial, and they only have 180 participants enrolled. And then we have some active studies that are going on. They're still collecting data, but they're not recruiting LIM kids. The CONNECT study involving dimethylfumulate and then teriflunomide TERI kids is they're still not recruiting now, but they are still gathering data from those clinical trials. So you say, why is it so difficult with clinical trials in the pediatric population? There are a lot of challenges that need to be addressed. You have time to complete enrollment due to the limited number of candidates, and I spoke about that. You have these big, gigantic trials with the adult population, but very small trials. You have limited trial experience for those sites that may be enrolling. You have a low rate of consent from eligible participants due to site, design, travel, and burden of visit frequency. Think about the pediatric population. If a child is going to participate in a pediatric trial, it can be very difficult because you got to have a parent there to accommodate that child. They've got to travel. They've got to take off work. They've got to miss days. You've got other siblings or kids that may be involved that need care in addition to the care that the child is receiving. So all those things can pose a lot of challenges to involving pediatric patients in clinical trials. You may have a family that has fear of trials, such as my patients who live in my area who are predominantly African American, and they have knowledge of bad experiences in the past with clinical trial involvement. Then you have those ethical concerns about clinical trials, such as the use of placebo, especially in the face of very active disease in a pediatric population. Who wants to withhold treatment from a child because they they want to participate in a clinical trial and they have very, very active disease. Then you have those financial risks again that we talked about and those site-specific challenges. A protocol may involve an MRI scan, and a lot of times protocols are made without the input of the people who it primarily will affect. And so those things are not addressed before the protocol is made, and it's difficult for our participants to come in. They may require like a 3T MRI. Well, if your facility doesn't have a 3T MRI, then that kind of negates the possibility of being able to participate in the trial. Other treatment challenges include shared decision-making. You not only have to get the parent to be actively and involved in the decision-making of a medication, whatever you decide to use, but you also have to have basically you have to have the child to agree to basically going on a medication. I tell my parents all the time, if they're younger, and like I got a 12-year-old, and we decide on an oral medication, and they're at home, and they're actively being reminded by a parent to take an oral medication, that may work out until they become teenagers and they become busy, or they're young adults and they decide, I don't want to be bothered with taking a medication every day. My famous story is a 16-year-old boy who was being raised by his grandmother, and he was on an oral medication that I will not name, and his grandmother was saying, you know, he had some changes, significant changes in his MRI, his annual MRI that he has. And grandmother was like, I don't know why his MRI is changing. He's taking his meds. And I said, we're not sure about that, are we? And she went home and she flipped over his mattress. And she finds the pills under the mattress. And she calls me frantically on my cell phone. All my patients get my cell phone number. I practiced that for 18 years. And she called me frantically and she says, I know why his MRI has changed. And so we had a conversation with him and his mother and his grandmother about changing his therapy to something. And so the decision-making about which medicine to use can entail so many different things when it comes to pediatrics. And again, I'll say the insurance approval is a big challenge because as a clinician, I may want the patient to go on a certain medication, but if the insurance will not approve it and we cannot get another source of medication, then that's going to be an issue. Adherence to medications may also involve memory and mental health issues. If a patient does not have the mental capacity to take a medication, especially if it's something that's going to be self-administered, that may prove to be an issue. Again, parental involvement. The question to need, if they need the treatment. A lot of adolescent patients have this Superman effect, what I call. They feel good because they're taking their medicine, but they don't understand that they're feeling good because they're taking their medication. They decide, okay, I'm not going to be on this medication because I feel so good, but they don't really understand the impact of taking medication and taking it and being adherent to taking medication. Then they may have ill side effects that they may not be sharing with their caregiver. They may not be sharing with you as a clinician. And then again, they have poor decision making when it comes to making appropriate decisions. Other unique challenges in pediatric MS, it can occur during growth, maturation of the spinal cord and brain. It may occur during or before puberty. It may have some psychological or physical effects. A lot of my patients, if you put them in this room and they are sitting here with their peers, they don't look different. So they may have some cognitive issues. They may have some social issues because they don't have a next door neighbor. Like people who have multiple sclerosis, you can just about find somebody in your neighborhood that has multiple sclerosis, but you can't find somebody that has pediatric MS. And so they have issues with social anxiety and other social issues that may impact how they feel about the disease process. It may also impact their ability to learn because of some cognitive issues. In order to meet the challenges of pediatric MS, you need to meet the child where they are developmentally, consider the things that are important to them based on their developmental age. It may be different for each and every child that you care for. And again, I cannot re-emphasize the shared decision-making that needs to happen, not only with the patient, the caregiver, but also the care providers, the individuals like myself who are providing care for patients. Everybody needs to be involved in decision-making in educational efforts. Adolescent issues in particular, they have a desire and a need to become independent. They want to establish a social identity. They have concerns for peer acceptance, self-recognition. They are often influenced by their peers. They have increase in risk-taking, and they have a concern over physical image as well. My most recent thought about this is a young man who was an identical twin and had been newly diagnosed at the age of 18 with pediatric onset multiple sclerosis. He had had symptoms when he was 16, but didn't get the diagnosis until 18 just because he was staying in a rural area in Alabama and could not get to us as care providers. He received 2 doses of medication. and his twin gave him fentanyl, and he died immediately. His twin is now been diagnosed with multiple sclerosis. So peer influence. He was influenced, had never, had dabbled and dabbled with marijuana and alcohol, but was never involved in any other illicit drug use and was given 1 dose of fentanyl and died. And his twin brother gave him the drug. And then his twin got diagnosed with MS. This is my sex, drugs, and rock and roll picture. When you think about an adolescent brain, you think about all these things that they're dealing with. All the influences that happen, fashion, drugs, rebellion, mood swings. And I show this to my parents because they come in and they're like, oh my God, I can't deal with this. And I'm like, here it is. This is what you're dealing with. All these things are running across each other, and then we're adding multiple sclerosis on top of this. A third of our pediatric MS patients have cognitive deficits. Cognitive challenges may be accompanied by a decline in academics. Cognitive symptoms may reflect moods of depression or other mood disorders. There also may be some pre-existing learning disabilities that have not previously been identified. There was a study done by some of our, I think, 10 centers in our pediatric network, and there was all these myths about pediatric MS patients having more cognitive issues. They looked at 72 or 77 pediatric MS patients. They compared it to 99 healthy controls and 66 adults with MS who were newly diagnosed had about the same length of time of diagnosis as the pediatric group. And it was found that the pediatric patients had no difference than their healthy controls in cognitive screenings, and that they performed even better than those adults that had MS that had that same length of time to diagnosis in the adult group. So how do we evaluate cognitive issues? I tell patients when they are newly diagnosed and their parents that they need to have neuropsychological testing. Formal testing to tell us if they have issues with executive function. Even those patients that my parents say, but they make all A's in school. We still need to do cognitive testing with them and repeat that testing at least once a year or once every 2 years to make sure that they have the accommodations that they need so that they're the most successful. We assist them with 504 plans and IEPs. We discuss with the school professionals so that we ensure that they get the quality education that they are afforded as a student in the United States. And we also advocate for our teens and teach them how to advocate not only for them, but teach them how to advocate for themselves as individuals. Education and support of the child is very important. Again, provide that age-appropriate education for the child. Reinforce symptoms of relapse. Discuss symptom management, how to manage symptoms. Yes, we have to have the sex talk with the boys and the girls because they need to understand that they need to know about how MS can impact their body. Evaluate coping issues, refer them as necessary, provide that brief information. You don't want to overwhelm them with information. For my patients that come for their 6-hour infusions, 6 to 8 hour infusions, I take time, usually about an hour, and I discuss any issues that they may be facing, but I don't overwhelm them with too much information so that they will retain that information. And then also talk to them about general health, getting vaccinations, getting immunizations, playing sports, doing all the other things that they want to do, and ensuring that they have health screenings when it comes to their eyes, especially if they have multiple sclerosis. Education and support of the caregiver. Make sure that as a provider that you recognize caregiver burden when it comes to pediatric MS. Discuss disclosure of a diagnosis. I often talk to families about grasping the diagnosis and what all it entails before you go putting it on the signboard, because people will overwhelm families with questions and comments about pediatric MS, because they often will refer to adult MS patients that they know about, and it's not the same. Encourage family adaptation, promote advocacy and decision-making, and I also encourage my parents to gather and advance their own knowledge about MS. Transition of care is very important, and that's when you move that patient from that pediatric clinical site to that adult healthcare system. Why is it so important? I think that all patients with MS require follow-up to optimize the benefits of disease-modifying therapies and to optimize care that they're being provided. MS has a very unpredictable nature. It's been less unpredictable since we've got all these new disease-modifying therapies that are putting people more at the area of NIDA. But adolescents tend to adhere less as their adherence tends to decrease over time. They start getting busy, they forget about the things that need to be important, and usually some of them have higher disabilities, and with those disabilities, they need more transition of care assistance. There are a lot of risks related to transition in the MS population. You have those lapses in insurance coverage. That patient that's been on a Medicaid program until they turn 18 years of age is now at risk of losing coverage. And you got to come up with some ways, and you can't wait until the day of their birthday to do it. So usually I start talking about insurance today or shortly after they get diagnosed, because we've got to come up with a plan. Not seeing appropriate providers. They normally don't go and see appropriate providers. They will use the ERs and the urgent cares for their care instead of seeking out appropriate providers who may have their best interests and know about the research and all the other bells and whistles that may come with seeing a specialist. And then they have a loss of independence usually. Poor transition will cause gaps in healthcare coverage, like I said. It may cause psychosocial issues, mental health concerns, and then they're at risk for increased medical vulnerabilities. What things do I talk about when I talk about transition? I talk about them understanding their disease appropriately, age appropriately. I learn them how to self-advocate. I teach them about how to seek emergency care. I also talk to them about the right to privacy. And if they're not able to navigate their own system, their own healthcare system, they need to get a parent involved. Because once they turn 19, unless they sign paperwork that says that they can have their parent incorporated, then their parents are not contacted and they don't have the assistance that they need. I also talk to them about medical forms and referrals, insurance and co-payment. They have no clue about insurance and co-payments. They just walk up to the desk and sign their paper, and the lady says, I need $20 co-payment. They're like, my mom's gonna handle that. And I'm like, they don't have a clue. So you have to talk to them about these things. Birth control methods we talk about very early on as well as mental health support. Other topics include medications, refilling prescriptions, appointment scheduling, transportation, drug allergies. They need to know all these things about their health care. When they are newly diagnosed, parents, we're helicopter moms and helicopter dads, and we take on all those roles, and we don't let them navigate the system. And then when they turn 18 or 19, they don't know what to do. And so you have to provide them with the education that they need to be able to transition into taking care of their own selves. Fostering independence, we've talked about that. The best place for transition of care information, if you have not been, is Got Transition. I have it listed here. These are resources not only for parents, patients, but also adults and pediatric providers. They have awesome resources there. I would suggest that all of you go to this website because they have good handouts about transition for any type of chronic illness. Early planning and intervention are imperative to successful transitional care. Wrapping it up, the diagnosis of pediatric MS and the treatment of pediatric of MS is very challenging for clinicians, for families and teens, as well as their caregivers. Unique challenges and experiences due to the development of the child at the time of the diagnosis should guide how they are cared for and managed. There's a risk of developing major motor disability and cognitive impairment early in life, and it may be significantly reduced with a pediatric MS diagnosis. Successful transition of care involves and includes the input of everyone that is involved. This is the end of my talk. And I hope I made my time. Did I make my time? What Connie didn't tell you, she is one of my mentors that kind of raised me from the very beginning when I knew nothing about MS. Thank you.
We're good friends. So thank you, Yolanda. And you're going to have to stand here and help me get
Yes.
Andy's slides up. So your next speaker is our last speaker for this morning, but Anthony Feinstein has been part of the MS program here, the fundamentals program, for many years. Weren't you with us the very first time? Yeah, he was. There he goes. Yeah,
It's gonna
it-
pop
it
up.
rotates itself.
Yep.
And he is a professor of psychiatry at the University of Toronto. He runs a MS neurobehavioral research lab, and he directs the neuropsychiatry program at Sunnybrook Health Sciences Center and the Barlow MS Center in Toronto. So that's very short. You know, I usually introduce him with a much longer introduction because he's led a very interesting life. So someday, if you have a chance to talk to him sometime, I'm sure he'd be happy to share it.
Thank you. So thanks, Connie. Connie always invites me back to give a cannabis talk. My lab's done a lot of cannabis research over the years, and for those of you who've heard my talk before, there'll be a bit of repetition, but we also have new data to share for you on things like resting state, default mode network, and how sex may influence cognition in people with MS who use cannabis. So those are my disclosures. So what to make of cannabis? I don't know what it's like in your community, but in Canada, it's really quite remarkable. The high street is filled with cannabis shops, sometimes next to one another. So since the drug has become legal, there's been an enormous uptick in the usage of cannabis. You may have seen a report recently in the New York Times about how elderly people who use cannabis are now starting to show up in the emergency room with side effects. And I think, as we come to grips with a new drug, as we do with any other medication, we need to understand what are the benefits, if there are benefits, and what are the side effects. And I'm going to walk you through a number of studies that we've done focusing on cognition in particular. So what to make of cannabis and cognition in MS for clarity amidst the haze, because there's a lot of uncertainty. And physicians who work with people with MS don't know what to tell their patients when it comes to cannabis. And many people with MS want to use cannabis. So there are a number of aims from my talk. To appreciate the link between cannabis and cognition in MS, I'm going to speak about smoked or vaped cannabis, to understand how brain function and structure can give us clues as to what's going on with cognition, to appreciate that cognition can improve with cannabis abstinence, that's really important, to realize there may be sex-linked cognitive effects of cannabis use, which is new work that we're doing, and to understand the importance of self-awareness and metacognition in determining why people with MS persist in the use of cannabis. So this is a study that we did a few years back. One of my students did it. In fact, Brenda Banwell's daughter was on my lab at the time. That's Emma Banwell. And we looked at a representative sample of people coming through our clinic, well-educated individuals, predominantly relapsing remitting people. And we had a look at why are they using cannabis. And if they come to a psychiatry clinic, the uses are going to be different from those attending a neurology clinic. But they use it for things like sleep, pain management, treatment of anxiety, spasticity, depression, recreational use, or multiple factors. And they will differ slightly between neurological and psychiatric clinics. A little bit about cannabis, because it's got a fascinating history. It's derived from the plants Cannabis sativa and indica. It contains over 60 plus cannabinoids, 2 of which are of particular interest to us. The THC is the psychoactive component, first isolated at the Weizmann Institute of Science in Israel in 1964. And then you've got cannabidiol, CBD, which does not have psychoactive properties. That was first found or isolated at the University of Illinois. And there's a big difference between the two, and much of our research is focused on the THC, or the psychoactive component. It's very important that you remember that, because I'm going to make a very strong pitch that I think the THC component is injurious to people's health. We're not talking about CBD, we're talking about the psychoactive part of cannabis. The drug's been around a very long time. This is going back to the 9th century. I can't translate that directly for you, but I can give you the gist of it, which is that we're using intranasal preparation. It was helpful in terms of pain, uterine pains, preventing miscarriage. So real therapeutic benefits, going back a long time. René Descartes was a great fan of cannabis, and I'm sorry if you heard me say this before. He was a philosopher, a mathematician, and a physicist. He really liked cannabis. He liked it so much that he left Paris to go and live in another European city where the cannabis was better. Do you know where he might have chosen? Everyone gets right, Amsterdam. And this is one of his aphorisms, I think, therefore I am. Very profound philosophical thought, which he probably arrived at when he was high. This is a study that appears in The Lancet, a high-impact publication going back to 1897. They first described the oromucosal use of cannabis. Onset was very quick. We know this, within 45 minutes. The individual was obviously intoxicated. After a couple hours, the intoxication wears off and you get a rapid recovery. And then one of the great doyens of medicine, the Canadian William Osler, was a big fan of cannabis. Because remember, in those days, cannabis wasn't illegal. It's got this fascinating history. Cannabis was very much part of the therapeutic tools that physicians used. But then, it became illegal, it fell off the map, and now, of course, it's come back, and it's around. But Osler thought that cannabis was very effective in terms of analgesia, and he promoted it in his famous textbook of medicine. So this is a drug with a celebrated history, and in many ways, very positive history early on in the history of medicine. The most common use is inhalation. Most people vape now. It's often smoked in combination with tobacco. There's a rapid absorption, as I mentioned before. That was the Lancet Urology paper showed you. The effects, the physiological and psychological, last for about 2 to 4 hours, but it can be ingested as well. That's why you have the gummies and the cookies, etc. Just takes a bit longer to ingest it. The levels take a little slower to rise when you inject it as opposed to inhaling it or smoking it. It's also known for neuroprotective effects. It's anti-inflammatory. It modulates the immune system. It can help with cerebral insult through trauma, ischemia, excitotoxic stress. So you can see why the drug was thought of in a positive light going back decades, and still is by many people thought of in a positive light, the benefits of this drug. And there are different kinds of cannabis receptors, the CB1 in the central nervous system, the testes and the uterus, and the CB2 involved in the immune response in the spleen, the tonsils, and the lymphoid tissue. The cannabis metabolites are very important. We look for those when we do our research. The primary metabolite of THC is 11-hydroxy-THC. 20% of the drug is excreted in urine. It's very strongly lipophilic. That's why if someone smokes a joint and then you test their urine, they will test positive for up to 28 days for 1 month. So many people swear off they've never smoked it. You do a routine urine screen and they test positive. So the drug's around for a long time because it's lipophilic. And there's also cannabis dependence. People don't realize this, but there's a very well-defined syndrome. It's the inability to stop using the drug despite wanting to. People spend a considerable amount of time trying to procure cannabis. It disrupts their social and their occupational lives. There's an escalating pattern of use, as you find with tolerance. Persistent use despite side effects. And then when you come off the drug, there's a withdrawal. There's reduced concentration, irritability, loss of appetite, depression, insomnia. This is a very, very important point because when you're doing a cognitive study and someone's just come off cannabis and they're going through a period of withdrawal, you don't want the withdrawal effects to confound your cognitive results. So this is something that we have to take into account when we do our cognitive studies, as I'll show you. So what about healthy subjects, cannabis and cognition? Let's just step away from multiple sclerosis for a bit. How does cannabis affect healthy people and their cognition? And here you've really got to look at the literature very, very carefully. They're the acute effects. So you test someone, they ingested it or smoked it a few hours back. I think there's compelling evidence that if you test someone when they're intoxicated with the drug, you will find deficits. So no one's going to doubt that. What about the short-term residual effects? The person's been abstinent for several hours to several days. What does the literature show? Well, probably the effects still linger, but they're less apparent. So you're not going to get the same kind of deficits in someone who's acutely intoxicated. What about the long-term residual effects? This is someone who's been abstinent for several weeks. And here the data is equivocal. In some people you find some deficits, but in others their cognition is returned to baseline. But there are many potential confounders with all these studies, and these haven't been taken into account. The frequency of cannabis use, the duration of use, the strength of cannabis, which is very, very important. The drug that's now on the streets in Toronto is fundamentally different to the drug that was around when I was at medical school. And my disclaimer is, I didn't inhale. But seriously, it's a very, very different drug. It's a designer drug now. It's far, far more potent, and potentially it's got a lot more cognitive effects. And then in the abstinent group, are deficits linked to residual cannabis, or is someone going through withdrawal, which could affect their ability to perform cognitive tasks? So you have to look at that as well. The very best study, I believe, of healthy people and the negative effects of cannabis comes from New Zealand. A 25-year follow-up study, a prospective study, birth cohort, over 1,000 subjects, index cognitive assessment at 13 years of age, and then they reassessed the individuals at 18, 21, 26, 32, and 38 years of age. A fantastic longitudinal study putting them through cognitive assessments. So 25 years on from onset, from 13 to 38 years of age, they did a detailed neuropsychological assessment. And the results were pretty compelling. If use began in adolescence and the individual continued to smoke regularly, defined as more than 4 times per week, by the time they got to middle age, they had significant, probably irreversible cognitive deficits. And I think that really, taps into my colleague who spoke before I did it. But you're dealing with a pediatric population as well, a developing brain, a brain that's going through so many changes, not properly myelinated. When you're using a drug that's potentially harmful to cognition, and you're starting it when you're very young, and you're doing it regularly, then you may well end up with fixed deficits. If it's the occasional puff or the occasional recreational use, it's probably a benign drug. If you use it a few times, it's not going to leave you with persistent deficits. As those persistent users who start young, as a neural system is starting to develop, moving from transition from adolescence to adulthood, that you can get a lot of problems with this drug. So let's shift gears into people with multiple sclerosis now. Just to remind you, cognitive difficulties are very common in people with MS. Clinically isolated syndromes affecting about 1 in 3 people, with relapsing remitting up to 40%. As you get towards primary and secondary MS, the rates of cognitive impairment are very high. What happens to these individuals when you add a drug like cannabis? And the very first study, I came into this inadvertently. One of my fellows did a retrospective study, a cognitive psychiatric study. We went back into an old data set to have a look at how many people had said they were using cannabis. And in our lab, we've developed a computerized version of the symbol-digit modality test. You're very familiar with this test. It's a sentinel cognitive test for people with MS. And our computerized test is you've got the computer screen in front of you. There's the code, numbers 1 to 9 in 9 different symbols. Then 9 boxes below where the symbols appear. The computer beeps. You have to match the symbol with the number as quickly as you can. When you get to the end of the line, it goes blank and it repeats 8 times. And we had a look at this data, and we divided up the data into people who were cannabis users and those who were not. And the results were really quite striking. You've got your 8 iterations of the SDMT along the x-axis, you've got y-axis, you've got time in seconds, and you can see that the cannabis users, very small sample, only 10 individuals, they were about 50% slower doing this test than the people with multiple sclerosis who were cannabis naive. And the groups were well matched on EDSS, age, etc. So a clue, a tentative clue in a very small sample. We didn't have urine confirmation that they'd be using cannabis, but you got here a tentative clue that something's happening to processing speed if someone says they're using cannabis. So based on that, the limitation, small sample size, limited cognitive battery, etc., we went and did a bigger study in which this time we had two groups of individuals, 25 people with multiple sclerosis who used cannabis, 25 were cannabis naive. This time we actually could screen the urine to see whether they were indeed cannabis naive. We got the demographic data. We matched them very well in terms of years of education and premorbid IQ and many disease variables. So two matched groups. And we gave them this, here are the demographics. You can see it's an interesting demographic. When you look at the cannabis literature in MS, you don't see the typical sex divide that you see in MS studies. You notice about 3 females to 1 male, but when you look at the cannabis data, it's about 50-50, which suggests that more men are still using cannabis than women if you've got multiple sclerosis. But you can see it's a well-matched group demographically and neurologically. And we gave them this comprehensive MS battery, the MACFIMS, the minimal assessment of cognitive functioning in MS, and I marked the differences in blue, but the group that was using cannabis had more deficits with information processing speed, more executive dysfunction, and they had more global impairment. In fact, about 60% of the cannabis users were globally impaired, defined as you're impaired on 2 or more cognitive measures, versus about 30% of the individuals who were cannabis naive. So more cognitive problems. The third study, we brought in imaging to see could we come up with a mechanistic understanding for what was going on in the brains with people using cannabis. And here we had to be very careful. We did not want individuals who were acutely intoxicated being in an MRI, because we know this group is going to be impaired. So there's a company in France that makes something called NarcoCheck, which is actually very useful. You can just get a buccal smear, and it will tell you whether the person has used cannabis within the last 4 to 6 hours. And if they have, we don't put them into the scan. We're not going to waste thousands of dollars on someone who's high because we know what the result is already. So we made sure that this group was not acutely intoxicated. But once again, we had cannabis users versus non-cannabis users. We wanted to make sure that the people coming off cannabis weren't going through withdrawal, so we didn't want that to be a confounder for our study. You can see here the demographics. Once again, it's a well-matched group. We gave them a slightly different cognitive battery this time. We used Stephen Ray's brief repeatable battery, where there's measures of verbal memory, visual memory, 2 measures of processing speed, and verbal fluency. And you can see once again that the cannabis group had more deficits with respect to spatial memory and on the PASAT. And then we put them into the scan and we gave them the SDMT, Simple Digital Modality Test. We wanted to see how their brains functioned on and off cannabis. There's a very well-defined neural network for the SDMT in healthy people, so we know what brain regions to look at. And we wanted to see how did people with MS respond on and off cannabis. It was a block design. Individuals are lying there in the scan. You've got the code that's familiar to you by now, numbers 1 to 9. They're the different symbols. When a number matches a code, you push the button. So you're now getting a measure of accuracy, but also speed of response. You can measure psychomotor response. And we did 11 blocks of 6 single-digit pairs. And here you see the performance over time. This is response time. The cannabis is appropriately in green. The non-cannabis group is in orange. And you can see people get better over time. They get faster, which is practice effect. But the group in green is slower. Their response time is slower to push the button. So the reaction time is slower. And there was a trend, didn't read significant, but there was a trend for the cannabis group to make more errors as well. When we have a look at the brain imaging, it's really quite fascinating. So this is a within-group activation. This is real time. They're doing the SDMT. And you can see that divided up into 3 colors over here, the cannabis group in green, the non-cannabis group in blue, and there's certain areas that are going to activate in both groups. There's going to be overlap because they're doing the same test. You'd expect that. And that's shown up in yellow over here. So lots of areas of commonality because they're all doing the same test. But just from eyeballing that, you can see there's a lot more blue activation compared to green. And when you do with a between group comparisons, so you've kind of gotten rid of all the common areas, you can see over there that there's more blue activation. And I don't know whether you can see it on this because it's quite bright in this room, but if you have a look at the area where there's the thalamus, and I want to see if I can do this without, does this show up on the screen, the arrow? Yeah, so there's no or significantly reduced activation in the thalamus in the group that's using cannabis. And what cannabis seems to do is suppress neural activity in a very key cognitive area, in this case, the thalamus. So from this, we concluded that there was a trend for the cannabis group to perform slower on this test. There was no real difference in accuracy of response. Both groups activated this very well-defined neural network that we know from healthy controls, prefrontal parietal neural network, that's been well described for information processing speed. But the main difference between the two groups was reduced activation, particularly in the thalamus, in the group that was using cannabis. We know from previous studies, forget about cannabis, previous MS studies, that the thalamus is a key hub in the neural pathway for the SDMT in people with multiple sclerosis who often have to overactivate the thalamus to do this particular test. What cannabis seems to do is turn this off. The next study was to go and look at a structural data, to look at the volumes of gray matter, white matter, and lesions. And in fact, there was no difference between these two groups. The metrics were very similar. But once again, it's more complex. These are the gray matter areas involved in the particular cognitive tasks that we gave them. I won't repeat them over here. You see them up on the screen. And those are the key white matter areas. And when we look at them individually, so here we've got the effects of cannabis use on gray matter and cognition in people with MS. This is a partial least squared analysis. You can see the topographical map over there. You've got your 3 MRI cuts in your sagittal, your coronal, and your axial scans. On the one hand, you've got your cannabis users. They're in white. You've got the dark areas of the non-cannabis users. Those are the cognitive measures below. The SRT is a test of verbal memory. The 1036 is a test of visual memory. You've got the controlled oral word association test. That's verbal fluency. You've got the SDMT and the PASAT. So those are the cognitive measures. When you look at the non-cannabis users, you will see the error bars are above the horizontal axis with respect to the simple digit and the PASAT. In other words, there's an association between processing speed and those gray matter areas in the context of cannabis. When you look at the people who are not using cannabis, when you look at the cannabis users, you can see an error bar above the horizontal line for the SRT, in addition to the PASAT and the SDMT. So what this is saying is that, yes, processing speed is important and is linked to brain metrics in cannabis users, but memory is as well. Memory is now entering into the equation when you start using cannabis. In other words, memory is potentially being affected in the context of cannabis use. And you see this over here perhaps even more dramatically when you look at the white matter. You've got your topographical maps over there, you've got your cognitive variables at the bottom, and when you look at the cannabis users, you can see the error bars are all above the horizontal axis with respect to simple reaction time, SRT, selective reminding test, the 1036 visual memory test, the PASAT, and the SDMT. You don't see the same in people who are not using cannabis, that the error lines for the selective reminding test and the 1036 are below the horizontal. And so how do we interpret this? In the presence of cannabis, volume reduction in certain brain regions is more closely linked to cognitive compromise, not just information processing speed, but also memory. So yes, we know the brains are vulnerable. We know that there's atrophy. If you're using cannabis, that atrophy becomes more significant, not just for processing speed, but also for memory. And that fits very nicely with the structural and functional data that I've shown you earlier. So now what happens to people with MS when they stop using cannabis? And this was a study we published a few years back, very challenging study because we had to take people off the drug for a while, 2 demographically well-matched groups. We gave them Steve Rayer's brief repeatable battery. One group remained on cannabis, the other group did not. We gave them very frequent urine checks to make sure that the one group had come off cannabis was indeed compliant. And we had to control for hydration in measuring things as well because we didn't want this to become a confounder in terms of our data. So we've got our two groups over here, our cannabis users and our non-cannabis users. They're demographically matched except for disease duration, which we were able to control for. Here we can see the urine metabolite, the THC urine metabolites. The group that remains on cannabis, the dotted line, remains very high over the course of a month. The group that comes off cannabis, they started at a slightly lower level, but by day 28, the cannabis has gone from their system. At day 1, we did a cognitive assessment. At day 28, we repeated the assessment. They had MRI at day 1 and at day 28. And here we have the data. So at time 1 and time 2, you can see that at time 1, we've got the cannabis group versus the non-cannabis group. There's absolutely no difference in their cognitive profiles. SRT, selective reminding test, a test of verbal memory, 1036 visual memory, the PACET, the simple digit test of information processing speed, the Coward is verbal fluency. So, both groups are on cannabis. At time 1, we don't see any differences. By time 2, there are very significant differences. By day 28, the group that's come off cannabis is doing better across every single cognitive measure. Here we've got the within group. So the group that stays on cannabis, when they come back and retest it after 28 days, their cognition really hasn't improved. They haven't even benefited from practice. If anything, you can see that their visual memory has declined. But the group that's come off cannabis, the in-group analysis, you can see how their cognition substantially improves across all the measures. So how does this show out in terms of brain metrics? So we gave them this paradigm of working memory called the NBAC. It's a very well-known working memory paradigm, which I'll just explain to you. Here we've got a group of individuals lying in a scan. They're presented with cards like this. And the zero-back task is a very simple task. When you see the target, which is an X, come up on the screen, you just press the button box. With the one back, you press the button box when a letter repeats. And here you can see that the letter L repeats. That's when you push the button box. And with the two back, it becomes more complex. When a letter repeats once removed from the previous, that's when you push the button box. So you can see D goes to L, but then D comes up again because it's one removed. That's when you push the button box. So, there's a 3 back and a 4 back. You don't want to make it too complex. So we stopped at the 2 back. It's a very powerful test of working memory. Once again, there's a very well-defined neural network for this task as well. But here we've got the data for the NBAC. And you can see at time 1, both groups are still taking cannabis, and there's absolutely no difference between the two of them on the NBAC task. Their accuracy is the same, their speed of response when they push the button box is the same. But when they get to time 2, there are very real differences. The group that's come off cannabis is quicker on their reaction time, even for the control, even for just pushing the button box in response to an X, they do it quicker. And they're more accurate when it comes to things like the 2 back, and they're faster. So this is a group that shows improvement on working memory. And as I said, there's a well-defined neural network for this in healthy people, which we apply to our analysis over here. And you can see here, this is at time 1. Those are the brain areas that we know are pivotal for this particular task. And I won't read them out to you, but you can see at time 1, there is no difference between these two groups in terms of their activation in response to the paradigm. But when you come to day 28, we start seeing very significant differences at the bottom here. Within the anterior lobe of the cerebellum, the precentral gyrus and the supramarginal gyrus are activating far more actively in the group that's come off the cannabis. And we can see it graphically over here. It's really quite dramatic. This is at day 28. The group, the horizontal group at the top are the individuals who have remained on cannabis. The group below are the cannabis withdrawal group. And just by eyeballing it, you can see how much more activation there is in the group that stopped using cannabis, in those areas that are very pivotal in doing working memory tasks. And here we see a great example of how brain plasticity is influenced by cannabis as well. We've got the cannabis abstainers on the right there, going from the 0 back to the 1 back to the 2 back. This is looking at cerebral activation in key areas, and you can see that as the task becomes more complex, the brain activation increases. The brain's working harder to get the task done. The group that uses cannabis tries to do exactly the same, and you see this increase from 0 back to 1 back. But as you get to the more complex task, at 2 back, the brain starts faltering, and certain networks start breaking down. They lack the plasticity to do the task effectively. And that's why they're slower to respond and they're less accurate. And here we just have the same thing. This is a within-group analysis. This is looking at the same group from baseline to day 28. We can see this is for the abstainers. And over time, you can see how the brain starts activating more within the anterior lobe of the cerebellum, the frontal lobe, the precentral gyrus, the supramarginal gyrus, the dorsocingulate cortex, all more active in the group that comes off cannabis, in the cannabis abstainers. And just to show you what this looks like in terms of the figures, you see it very nicely there. There's a baseline group at day 28, just a lot more activation as the group does its working memory task. So the conclusions are that wide-ranging cognitive deficits improve when people stop using cannabis. And this improvement is very quick, within 28 days. By the time the cannabis is out their system, you start seeing their cognition bounce back to probably where it was before they started to use cannabis. So this is some new data. This was published by my lab this week, looking at resting state. And I'll just run you through this very quickly. We focused on the default mode network, which is a key hub, as you know, in cognition. And by looking at these two graphics over here, you can see this is the cannabis withdrawal group at day 28, the cannabis continuation group. There's more activation in this key hub, the default mode network, in resting state. The person's just lying there in the scan. They're not doing any cognitive task. But the resting state activation is more pronounced of cannabis. And here we see the day 28 comparisons. Very key areas within the default mode network are more active in the group that comes off cannabis, the posterior cingulate and the right angular gyrus, which are known to be very important in terms of cognitive abilities. And over here, you can see this is an in-group analysis. This is a group that's come off cannabis. The scans at the top are looking at the prefrontal cortex, which starts activating in the group of cannabis. The scans below the line that should be labeled hippocampus, you start seeing the hippocampus start waking up in the resting state network when people stop using cannabis. So key cognitive hubs come online when people stop using cannabis. And we see this in resting state data. This is work in progress. And I think this is really fascinating. We know that women with MS do better than men when it comes to cognition. And a well-replicated finding that memory, in particular, is stronger in women with MS than it is with men. So what happens when they use cannabis? And you can see a little bit of data over here. At the top of the top of this particular cartoon, you've got something like the SRT, the selective reminding test. This is looking at men and women who are both using cannabis, and there's no difference in this particular memory test. And when you go here below the line, can I share this with you? We find that the selective reminding test starts becoming significant again. So as they start coming off cannabis, you start seeing the well-described sex differences. Here we've got some fMRI data from the simple digit modality test showing that when men come off cannabis, their SDMT improves, but when women come off, it improves much more. The brain bounces back more robustly in women. And when it comes to the NBAC task, which you're now familiar with, when you look at the data down here, here's the data for women, here's the data for men, here's the 0 back, the 1 back, the 2 back. You can see that as these women start coming off cannabis, the 0 back improves, the 1 back improves, and the 2 back improves. You don't see the same bounce back with men. In fact, at the 0 back and the 1 back, there's not a whole lot of difference. It only starts catching up at about the 2 back. So what this tells us is that, yes, the male brain is more vulnerable. Cannabis seems to kind of bring the two sexes together when you use it. It's a very powerful effect on cognition. But as people start coming off cannabis, the rebound or the bounce back is more profound in women than it is in men. We need to explore this a bit further. So this is my final study that I want to share with you. Here's the conundrum. When we finish our studies, we sit down with our patients and we show them the data. We show them their cognitive data. We show them what the imaging looks like. And we say, let's have a discussion now about your cannabis use. And in fact, every person who uses cannabis, whose cognition improves, goes back to using cannabis. And the question is why? You've got compelling data over here to show that your cognition is better, your memory is better, your processing speed is better, your executive function is better, your brain metrics look healthier. What is it about cannabis that makes you want to go back on the drug? What is it giving you? And we don't know the answer to this because this wasn't the aim of our study, but we're getting some clues. And it comes from metacognition and the person's awareness of their own cognitive abilities. So one of the scales that we gave our patients as part of the study was the Modified Fatigue Impact Scale. And that has a subscale looking at cognition. And these are the questions that the patients have to respond to, the alertness, the vigilance, thinking clearly, memory, et cetera, et cetera. Here we've got baseline, here we've got day 28. We're getting the data at both these 2 time points, and there's absolutely no difference between the group that stays on cannabis and the group who comes off cannabis. So in other words, people come off cannabis, we've got objective evidence that their cognition is improving, but they're not aware of it. They rate their cognition exactly the same. Their metacognition is faulty. They're not perceptive of their own cognitive abilities. The only part of the modified fatigue impact scale that differed was here in terms of activities. That the group that uses cannabis, who stayed on cannabis, told us that it made their social interactions more comfortable. The group that came off cannabis felt a little more anxious in social situations, and they found some benefits from using cannabis in social circumstances. But in terms of their cognition, they didn't have a clue because their metacognition is just not good enough to tell them that they're doing better. And we think this is probably a very key reason why they stay on it. They come off it, socially they feel a bit more awkward, they're not aware of the cognitive benefits, so they go back on it. And our next studies, we want to try and map the brain metrics that help us understand this, because there's a particular brain area called the insula, which is key in terms of someone's metacognition. What's going on in the insula of these individuals when they come to perceive or rate their own cognitive difficulties? So lack of insight into cognitive deficits, we think, is one of the main reasons why people with MS stay on cannabis despite compelling evidence that it's harming their cognition. So what do you tell your patients? I tell my patients, be careful with regular cannabis use. Like any drug, we have to kind of weigh up the benefits and the risks. And when my patients tell me that they find the drug helpful, I have to listen to them. It's not for me to say that it's not helpful to you. I can just give you some objective cognitive data. But if they say they feel better on it, even if they can't define why they're feeling better, it's still an important observation. So I tell my patients there will likely be cognitive compromise, and that the deficits may well be reversible with abstinence, which I think is important. But like any drug, you have to weigh up the benefits and the side effects of treatment. So we're feeling our way in this very difficult and complex area. And that's my talk. Thank you. Any questions?
Thank you for your presentation.
Right.
Thank you for your presentation. That was very helpful. So I just wanted to make sure I'm understanding this correctly. This is specifically the THC component
Correct.
of cannabis that we're seeing these kind of more adverse effects. I think I've been personally recommending the use of CBD for my patients for pain properties, sleep, etc. Is there any reason there could be any deleterious side effects from CBD?
Yeah. Not that I'm aware of. I don't think there's compelling evidence that is helpful as well. I think still waiting for the good studies for that, but certainly you're not going to get the same side effects that you're going to get with THC simply because it's not psychoactive. Yeah. Sorry.
Do you notice much difference when somebody is on the cognitive effects based by, I mean, we talked about gender, but what about age? When it's somebody, say, in their college years versus somebody, say, in their 40s, 50s, or beyond?
Right. Yeah, we haven't found any age effects yet. You always assume that it's going to be younger demographic using cannabis. And in the general population, it probably is, but I think they're starting to change now. I really do, because the drug is just so pervasive. It's just everywhere. So that's going to be a really interesting question. As the brain becomes more vulnerable as we age, what's going to be the effect? My hypothesis is that you're going to start finding an age effect. Yeah.
That was a terrific talk. Thank you very much. What do you advise about driving in people habitually using cannabis?
Yeah, I think that's an issue as well. I think there's Canadian data to show now that there are more, you're starting to see more accidents because of cannabis use. The bottom line is you should not drive when you're intoxicated, absolutely. You've got this brief window, right? So you get intoxicated quite quickly, but then it fades away. But you shouldn't drive when intoxicated, yeah. Any final points? Yes.
I know you talked about future directions given the metacognition data.
Yes.
I was wondering if you were considering any interventions to improve that metacognition so that patients can experience those
Yeah, that's a great question. I think first we want to get a better understanding of metacognition. You know, I tagged it on at the end of my talk. It wasn't a primary outcome for us. We just kind of went back and looked at it. We had a measure of metacognition that I don't think is the best. The modified fatigue impact scale wasn't really developed for that. So I think we have to get a better handle on what's going on with metacognition. Once we've got that, then that begs the next question, what do you do about it? How do you start educating people about the cannabis? But I think, you know, being a clinician and a researcher, my experience is that people are very wedded to their cannabis. They like it for all sorts. So we have to get a better understanding of why they like it so much. And right now I've got an imprecise understanding of that. Some clues over here that it might make social interactions somewhat easier for you. But I think it's going to be a lot more complex than that. So in trying to understand the attraction to the drug, we have to understand what's the drug giving them.
I was thinking about that too, like the social and emotional benefits.
Mm-hmm.
Like, why would I want to be more acutely aware of feeling cognitively
Yeah.
deficit,
Yeah.
even if I am experiencing some benefits from not being on.
Sure. You know, I didn't show you the data over here. We've got depression data. You know, one of the reasons why people say they use the drug is because it's treating my depression. We've got data to show the exact opposite, that as you come off the drug, your depression is getting less. But once again, they're still using the drug. Yeah, it is. It is. And so, you know, we have to have the humility to say we don't understand it. Let's try and explore it further.
Have you seen any differences in inhalation versus ingestion and whether one causes more harm than the other?
Yeah, not yet. It's certainly not in this population. The majority of people use it through vaping. It used to be smoking, and now it's vaping. That comes with, you know, with lung problems as well, by the way. Things probably shifting now in the age of designer cannabis with gummies and cookies and all the rest. And certainly that's a big risk factor for kids who see these things lying around and they pick it up and they eat it and they become toxic. I'm not aware of any cognitive differences between the two. There's going to be a slower absorption with eating it, but you can still reach the same high peaks. And by the way, none of this data pertains to the synthetic manufactured cannabis. We're not talking about Sativex and those drugs. This is just the street cannabis or the cannabis that the government of Canada provides, which, by the way, patients don't like. It's not potent enough. It's really interesting. They don't want to get the cannabis from the government. They want it from the high street. Good, thank you.
Tomorrow, if you come back to the playground, we'll be in the strand, and talk to them about cold. We'll try to get them less cold.
consortium